So now we begin our journey into the heart. And I know you probably have a basic understanding of how the heart works, but I want to go over some concepts and some basic anatomy to give you a better sense of how things are working here. I know we've gone over this in part when we did pulmonology in terms of blood flow to and from the lungs. But let's go ahead and get down some basic vocabulary here. We know we have four chambers, a left and right atria, and then left and right ventricles. So there's my right atrium, here's my left atrium. We have a right ventricle, we have a left ventricle. The right ventricle and the right atrium is going to be receiving venous blood from the body, coming from the superior vena cava. That's going to be delivering, blood from the head, and then and of course some of the neck areas as well. And then the inferior vena cava is going to be handling blood from the other parts of the body. But all that venous blood is heading to the right atrium. And the venous blood will go directly from the right atrium, and it will just drop down into the right ventricle. We have a check valve here called the tricuspid valve, and a generic name for any valve between the atria and the ventricle is going to be called AV valves. Okay, and that's just atrioventricular valve. But the AV valves for the right side and the left side of the heart are different, therefore they have different names. So the tricuspid valve, as the name implies, has three leaves. Again, as I said, it's a one-way check valve. We'll loop back to that point in a moment. So venous blood is just flowing into the right ventricle. And at the same time, I am having blood coming from the lungs. I know you know this, but coming from the lungs, from the pulmonary veins. And this is oxygenated blood, so this is going to be arterial blood, delivered into the left atrium, and then, of course, that's going to drop into the left ventricle. And again, it's passing through a mitral valve, and that is the other AV valve, but its specific name is mitral, because mitral is a kind of a hat that a bishop or higher ordered folks in some religious traditions will wear, like a Catholic church, a bishop will wear a mitral. It's just a two-leafed kind of hat that sits on their head. And so the mitral valve is just kind of an inverted mitral. So that's why they call it that. And again, it has two leaves. Anyway, so you're going to have the blood from the lung sitting into the left ventricle. And so now what happens is the heart is going to generate its own electrical impulse for contraction. And we probably have spoken of this before, but the heart does not need any input for contraction. It will generate its own action potentials to effect contraction of the atria and the ventricles. And we're going to go a lot into that in later lecture sections, but it is autonomous. The nervous system, such as the autonomic system, parasympathetic, sympathetic, certainly does have input into the heart, but the input is one of the nervous system modulating the beating of the heart, but the actual origin of the beat itself, which would of course utilize action potentials, starts from the heart. Again, much more on that later. But what happens is you have an electrical impulse will cause the contraction of the atria, then followed by contraction of the ventricles. And so let me tell you what doesn't happen. What doesn't happen is that all the blood from either the lungs going to the left atria or the rest of the body coming into the right atria, it doesn't just flow into the atria, then sits here and then waits for the atria to contract, and then the atria then pushes all that blood down to the ventricles. That isn't how it works at all. When the blood comes into the atria, because these valves are open, in the case the left side, the mitral valve, the right side, the tricuspid valve, blood just flows on through these one-way check valves. So by the time the atria contracts, most of the blood that has flowed through the atria is already in the ventricles. So the contraction of the atria is just to push a little bit more blood from the atria into the ventricles. So you have contraction of your atria. And then what happens is that you're going to have a following contraction of the ventricles. Now, as the ventricles contract, obviously you're reducing volume, therefore you're going to be increasing pressure. Going back to Boyle's law, we've talked about that before. So you're going to be increasing pressure as you decrease volume. Well, as I said, these AV valves are one-way check valves. So what that means is as the pressure goes up in these chambers here, it's going to slam those valves closed. So they're going to close, which means then that's going to push the blood in a different direction. So in case of the right side of the heart, the blood is going to be pushed through the pulmonary valves. And there's a pulmonary valve there. And the pulmonary valve, a three-leaf valve, is going to be pushing blood into the pulmonary artery. And the pulmonary artery, as you know, is going to be leading to the lungs. So all this venous blood is heading to the lungs for exchange of oxygen and carbon dioxide. In the meantime, we have blood again coming from the lungs where you've had your gas exchange, goes through the left atrium, goes into the left ventricle, and then when it contracts in tandem with the right ventricle, it is going to be pushed through this valve here, and this is called the aortic valve, and the aortic valve is leading to the aorta, which is this very large arch of elastic tissue, and the blood flowing into the aorta is going to be destined for the rest of the body going through the arterial system. So that's what happens there. So when the ventricles contract, both AV valves are going to slam closed, and then the pulmonary valve will be pushed open, and then the aortic valve will be pushed open, and then blood will flow through there. Now, what happens is after the contraction of the ventricles, they're going to relax, and when they relax, they're going to expand the volume, which is dropping the pressure. Well, you wouldn't want all of that work done to be pushing the blood into either the aorta or the pulmonary arteries to then flow right back into the ventricles because, again, fluid flow, gas flow, everything is driven by pressure gradient. So that means that the aortic valve and the pulmonary valve are also one-way check valves, and so when the pressure in the ventricles drop, then that means the blood will want to go back the other way, but these valves will close. That's the wrong one, over here. So these valves will close, keeping the blood in the arch of the aorta, keeping the blood in the pulmonary arteries so they can then push it downstream to wherever it is going to go. So that's kind of a review of the basic mechanics of what happens in terms of all the pressures and the contractions and such. Now let's go ahead and name some other parts of the heart and explore a few more concepts here. Since this is the left atria here, this right there is considered the left free wall. And then over here in the right ventricle, that is going to be the right free wall. And we're making a distinction between left and right free walls because what we have in the middle here is going to be a septum. And so in a sense, they're kind of a shared wall between the left and the right ventricles. Another point that we want to be aware of is that the bottom part of the heart here, we're going to call that the apex. And then I'm just going to draw, let's just go through here and just say that area of the heart there, that line area of the heart there, we're going to call that the base of the heart. So apex and base, the base is where your valves are, and the apex, of course, is at the bottom of the ventricles themselves. Now, one comment that I want to make about the left atrium, again, this is the one that is receiving blood from the lungs. You have another structure, and it's not really in the drawing, but I'm just going to just kind of go out here and say you have a left atrial appendage. And the left atrial appendage is kind of this little pocket, and you can go on Google and get better pictures of that. But it's there, and some people think that that existence of an appendage may cause clots to form. So we'll go, some think a risk factor for clots. Because anytime you have blood pooling, you run the risk of clot formation. And so there's actually a procedure there called the LAA closure. LAA closure. That's the left atrial appendage closure, where they actually go in and will suture it or close it off so you no longer have the appendage. Now, this is controversial, because whether or not the existence of the appendage actually does encourage clot formation, people argue about. So this procedure here is also controversial. Not everybody believes in its efficacy. Another idea, what's kind of cool, is that when the heart contracts, obviously things move, but when the heart contracts, the apex does not move. So apex does not move. During contraction. It stays where it is. So what happens is that the base of the heart is actually drawn towards the apex. So what you have here then is you have so it's being drawn this way. So the heart actually moves towards the apex. So the apex stays steady, and the entire base of the heart will move towards the apex during the heartbeat. Also, when the heart beats, there's a twisting motion involved. When ventricles contract. So the movement of the blood out of the ventricles is almost like you're wringing a rag. You twist to get all the water out. So the heart actually will twist like the wringing of a rag, and the base will be drawn towards the apex. The apex doesn't move, and those are some of the physical forces generating pressure in the ventricles so that it then pushes it out through either the arch of the aorta or the pulmonary valves. We're going to go a lot more in depth on that in a later lecture. Okay, I think I want to go ahead and just end this here, and then we'll pick up next time and explore another concept. So, see you till next time. Now that we have the basic architecture and have a general of the heart and have a general sense of how it works, I want to turn our attention now into the various cell types we find in the heart. And I'm going to basically put it into two categories, two types of cardiomyocytes, one being non-contractile and the other being contractile. So I want to first talk about the non-contractile cells or the non-contractile cardiomyocytes. They constitute or represent about 1% of all the cardiomyocytes. So again, by far, not that many of them, but they perform a very, very important role. Within this class of non-contractile cardiomyocytes, we have specialized cells who have an ability to generate their own action potentials, completely autonomous. Nothing else from the outside causes the action potentials to happen. So they're totally autonomous and can generate periodic action potentials. And so what I want to do in this next block is basically talk about how all this works. So we would call those autorhythmic, which again, the name pretty much tells you, auto, self-generating rhythm. And these are the cells that will do that. Another name that you will see them called or referred to as pacemakers. Again, same idea, that they're generating periodic action potentials in their pacing. Now, it is these periodic action potentials that are actually going to cause the heart to beat. So every time these specialized cells have an action potential, that is going to result in the beating of a heart, and then a little less than a second later, it'll generate another action potential, and then that will be another heartbeat, and so forth, so on. So I'm going to speak in generalities here, but there are three types of cells that can serve as pacemaker cells. Again, it's a little bit of an oversimplification, and we'll get into some of the weeds on this in the later lectures, but let's make it simple for now. So what you have here is a group of cells, and we're calling this the sinoatrial node, and we're going to shorthand it and call it the SA node. And the SA node is going to be right up here, okay, and it is near where the superior vena cava, and then we have an inferior vena cava, okay, which is there, is interphasing with this right atrium. So these specialized little cells called the SA node are going to be generating periodic action potentials. So they're going to be, their baseline tends to be around 70 to 80 action potentials per minute. Then we have another set of specialized cells, and these are going to be the atrioventricular node, and we're just going to shorthand that and call that the AV node. So there is my AV node here, and the AV node is also in the right atrium, but it is in the base of the right atrium, very near the tricuspid valve, or the AV valve that's between the right atrium and the right ventricle. So it also has an ability to self-generate action potentials, and its basic pacing is going to be anywhere from 40 to 60 action potentials per minute. And then the third general category we're going to call the bundle of His and Purkinje fibers. The bundle of His is going to be just this area right here downstream from the AV node. And then that bundle of His, these fibers are going to bifurcate and form here, and this is going to be called bundle branches. And so I'm going to have a left bundle branch, I'm going to say BB for bundle branch, and over here will be my right bundle branch. Okay, and they're going down the septum of the heart, and they're going to round through here, and then they're going to end up with these Purkinje fibers. And these Purkinje fibers are just going to be little branches that are going to be interphasing with cardiomyocytes that are of the contractile nature. And so they have their own inherent pacemaking, and they're going to be having action potentials anywhere between 20 to 40 action potentials per minute. So you may be asking yourself, well, if the heart is beating 70 beats per minute, which is typical, and I'm having all of these autonomous cells being able to generate action potentials, and if the action potentials then are causing contraction, that doesn't seem to work out very well because everybody's doing their own thing. So here is a key principle that I need for you to get your mind around, and we're going to be reviewing this over and over throughout the next few lectures, and that's the following principle, is that the fastest pace, the group of cells that will have action potentials in the fastest pace are the ones that's going to rule, and they will actually suppress the autonomous action potential generation of these other cells. So the fastest of these is going to be the SA node, which means they're going to be lighting off 70 to 80 times per minute. So if they're having action potentials 70 to 80 times per minute, the generation of those action potentials will actually suppress the pacemaking ability of the AV node, bundle of His, and the Purkinje fibers because they're the fastest pacing cells. So what that means then is that these cells right here are not going to be generating action potentials. They're going to be suppressed by the SA node. The general rule is the faster pacemaking cells will suppress any other pacemaking cells in the heart so that they no longer generate action potentials. So we would say or categorize these last two as latent pacemakers. Okay, they're there and they have an ability to generate action potentials, but they won't because they're being suppressed by the pacing of the SA node. In normal individuals that are healthy and everything, the contraction of the heart is going to be generated by the pacing of the SA node, the sinoatrial node. And so when that happens, in clinic, you'll be referring to this as a sinus rhythm. So a sinus rhythm is just a medical way of saying that the SA node is the one that is driving the pacing of the heart and in terms of its contraction. Okay, so I'm just going to go ahead and cut this one short so I can get into the next section as one block. So I'll see you next time. So last time we talked about the ability of the cells in the SA node to, in a very autonomous way, generate their own action potentials. So my purpose on this block here is to help you understand how that happens. There's no magic here. So how can cells have a rhythmic generation of action potentials, generates on its own without being caused by something else from the outside? Well, it all is about the nature of the channels that are in the membrane that will determine how the cell membrane behaves. So one of the qualities of these pacemaking cells is that they don't have a resting membrane potential. So it's never static at one thing. It's always undulating. So this is what I want to talk about now. Now, you might need to do yourself a favor because I'm going to be referring to the earlier lecture I had back when we did action potentials for the neurology part of the course. And remember, I had a set of lectures on potassium channels. You might want to go back and take a look at those because I'm going to be referring to these various types of potassium channels in this lecture and also in coming lectures as well. So again, a lot of this depends upon your understanding of how potassium channels work. Okay, having said that, let's get into it. So what we have here is a trace of the membrane potential of these special pacemaker cells, and we're just going to say, let's assume this is cells in an SA node. So what I have here is potential of the membrane, and I have time here, and so the thing that you immediately realize is there's no resting membrane potential. I'm just having cycles. So let's walk through the channels to see how this works. I mean, who are the players involved here? Well, I think I want to go ahead and start in the middle, so I'm just going to start right there. So what do we have as time goes on? I'm having a drifting of the cell membrane potential to be just ever increasing, less and less and less negative. And you can see that drift there. You'll note that the bottom, about as low as it gets is about 70 millivolts. And so it's going to drift a little bit less negative, a little bit less negative, a little bit less negative. So that means if the membrane is drifting less negative, that means I am moving charge across the membrane, and that I am, in this case, having sodium flow in a very steady way, and the delivery of the sodium is causing the membrane potential to be less and less negative. Well, if sodium is moving through, then that means it has to be moving through some type of channel. So let's go ahead and just do the line. We'll do the line all the way down here just to keep track of what's going on. So the first thing I want to bring your attention to is going to be this guy right here. In illustration, it has IH. Now, most of the literature will have a different name or term for this, and so we're going to say, and you'll find it as IF. That's what you'll see it most of the time. I don't know why this author chose H, but IF is what you normally see in the literature. And the F stands for funny channels. And they're called funny channels because they don't allow passage of electrolytes or ions through the channel if the membrane is above 0. In other words, any positive potential of the membrane, these channels completely close down. So these funny channels are permeable to both sodium and potassium. They're more permeable to sodium than potassium, but they are permeable to both. So what you have here is the shaded area here it's below the line here. So when you have a shaded area below the line, what that means is that I'm having a net positive flow into cell. And in this case, what I'm having is sodium is just kind of flowing through these funny channels. Now again, why would the sodium flow in? Remember we talked about it's one thing to have a channel open, but whether or not an ion will flow through that channel is going to be contingent upon the forces acting on that. And remember we talked about your forces being your concentration gradient and then the electrical forces. And so you calculate that together, we come up with a Nernst value, and then that's going to give you a sense of what the end resulting force is when we take in consideration concentration gradient and electrical forces. So you'll recall that the Nernst value for sodium is, plus 60 in that range. So what that means is that I have a pretty powerful force driving the sodium in, because we have sodium is also way more concentrated on the outside of the cell relative to the inside of the cell, plus inside the cell is negative, sodium is positive, sodium wants the cell membrane to be plus 60. So you have a lot of force driving sodium into the cell, and it will do so through these funny channels. Now, again, these funny channels, they're just a little bit open to sodium, so you're not having this massive flow of sodium coming in, but you're having enough of a sodium dribbling in to just gradually bring this voltage potential more and more positive. So you can see here I'm having, as the gray gets longer, that means I'm having more and more flow of sodium into the cell. Now, what else is happening during this phase? And by the way, we call this phase 4. Each of these has a number, so this is phase, let me go ahead and put the numbers in for you. This is phase 4, this is phase 0, and this is phase 3. So I got phase 3 over here, I got 0 here, and 4 here, just to get the idea. So I'm going to refer to these as phases. So phase, 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 and phase. So during phase 4, looking at the graph here, so we have sodium flowing in. This is going to be calcium, calcium, so calcium here, calcium. So no calcium's flowing in. I'll talk about the sodium-calcium exchanger later, but nothing's going on there. Oh, but notice here, I have these channels here, and these are going to be delayed rectifier channels. These are potassium channels, of course. And we talked about those in the earlier lecture. So what this is telling me here, now if the shade is above the line, what that means is that is indicating that positive flowing out of cell. So as far as potassium is concerned, because I have the positive here, then that means my net positive movement is out of the cell. So I'm having positive moving out of the cell. And remember over here, I said my net positive, and this is positive associated with sodium, my net positive associated with sodium is flowing into the cell. So what this is telling me is that I'm having sodium flow into the cell, I'm having potassium leave the cell. So I've got a swapping of a positive in, positive out, right? So if I have one positive sodium flowing in, one positive potassium flowing out, then that means there's no net movement in terms of the membrane potential. But what you see here is this is going in this direction here. What does that tell you? That tells you I'm having sodium flowing in, I'm having potassium flowing out, but my sodium inflow is exceeding my potassium outflow, leading to a net drifting of the membrane potential to be less and less negative. Also, what I have down here in this channel right there, we talked about this in an earlier lecture, this is going to be my sodium channels that are going to be associated with acetylcholine. Okay, and we talked about that in an earlier lecture. And where the acetylcholine comes from my vagus nerve. Vagus nerve as part of my parasympathetics. So I'm having a continual vagal input into the heart, a parasympathetic tone or vagal tone. And so when that vagal tone is there, depositing acetylcholine, again binding to those M2 receptors, which in turn is going to be through G proteins causing opening of these potassium channels, again, in response to the acetylcholine binding to the M1 receptors. So I'm going to have some potassium leaking out as well. But even then, still, the sum of this potassium here leaving the cell is going to be less than the sum of the sodium going into the cell, which again results in a less negative potential. So you got that going on. Then something interesting happens. And that is right about here, okay, and so we'll go down to some along in there. Something happens. Now I'm having a quick kick up here. So what's that all about? It's not the sodium that is doing this. Now something is different, and so the initial kick up is from this guy right here, and this is a T-type sodium channel, calcium channel. T-type calcium channel. And these are called transient channels, and they're transient because they open up very quickly and then they close relatively quickly. So they're going to allow calcium to come in. So this is below the line, so now I'm having calcium flowing into the cell. And then a little bit after that, I'm having my L-type calcium channels open up, allowing even more calcium to flow into the cell here. Now, mind you, I'm still having some sodiums flowing in, but the sodium flow, these funny channels, will begin to close off. Okay, you can see that there. But now calcium is carrying the day. So when I'm having these calcium flow in, and again, each one of them is carrying a 2 positive valence, so that's a pretty hefty charge flow in, and I have a lot of forces acting on the calcium coming in because I got way more calcium on the outside than I do the inside. In fact, the Nernst value for calcium is like in the 140 range, somewhere along in there, so it's really positive. So way more than even the sodium. So I have a lot of forces wanting to drive calcium into the cell. So that is going to cause a pretty good kick up in the increase, and so we're actually calling this an action potential. That is, my action potential happens right there. And again, this is because of the flow of calcium. You'll recall in skeletal muscle. You'll recall in nervous tissue that the action potential was driven by sodium through these voltage-sensitive sodium channels. Here, the action potential is driven by these voltage-sensitive calcium channels. So it will head up, and then all of a sudden, then it starts going the other way. So we'll go, let's go blue here. So something happens here. So we'll straighten that out. And look what happens. Now I am heading back down. So what is happening here? Well, you'll note now the T channels have already closed, so I've shut that faucet off. And my L-type channels, they're starting to close now. Again, they're voltage sensitive, so I'm choking off the calcium flow in. But look what else is happening at this point. And of course, I've just basically shut off my sodium flow, and so it's not moving in. So what is kicked up is my delayed rectifier channel. So it is kicking way up here. And so now what I have is a flow of potassium leaving the cell in excess of any positive charge moving into the cell. So if positive charge efflux is exceeding inflow of positive, that means I'm driving my membrane potential to be more negative, and this is kind of where I am over here as well if I go to the next beat. So now I'm having lots and lots of potassium flowing out in excess of any sodium or calcium flowing in, bringing this back down to this trough here. Then what will happen is that the delayed rectifiers will then begin to close down. Okay, so we'll go ahead and just so we can see the cycle here, draw it over here. And we're going down there. So now my delayed rectifying potassium channels begin to close. Okay, and so now I'm at the bottom here. Now they've closed back down, reducing the amount of potassium leaving the cell. And now what am I left with? Now I'm back to my funny channels. The funny channels then begin to open, allowing more and more sodium in, and we start the cycle over again. So because I'm having these very specialized channels that open and close by their nature, we've set up this membrane to be continually cycling, which is really, really interesting. So if you got the right kind of channels with the right attributes, you can create a cell membrane that never has a resting membrane potential, but will always be cycling, having an action potential, and then going back and having another action potential, and so forth. So I think this is really, really, really slick. Now, a couple other things that I want to bring your attention to that I have not mentioned, one being here, this guy right here. Okay, this is a sodium-calcium exchanger, and this is in the literature. You're going to see this is NCX. Okay, this is an exchange pump, and so I'm just going to cartoon it out for you. And so what happens here is it can push a calcium out, and then it will pull in sodium. So I got that. That's the nature of that pump there. This is not an ATPase pump. So this pump is generated or spinning, pushing calcium out. And of course, you go back earlier in the course when we talked about Gibbs free energy. And the take-home message of the Gibbs free energy is there's no such thing as a free lunch. So the energy scheme has to balance out. So remember all of this calcium coming in through these T and L channels? Well, if the calcium is flowing in, you better have a way of kicking the calcium back out, or you're not going to be having a long-lasting cycling going on here because you're going to run out of calcium. Given enough time, all the calcium ends up inside the cell. So I have to have a way of pushing the calcium back out. Well, as you'll recall, there's a lot of force driving the calcium into the cell. So that means I need to have a big energy source to push that calcium against its concentration gradient and against the electrical forces. This is where my sodium comes in. because as I'm sitting down here, in particularly the lower negative areas of membrane potential, remember, I have the sodium that wants to go in pretty bad. So I have a lot of electrical forces and concentration forces driving the sodium in if it can. Well, it turns out with the nature of this pump, it takes 3 sodiums to drive out 1 calcium. So the energy that is driving the ability to push a calcium out is going to be driven by the sodium concentration electrical forces driving the sodium in. So the sodium is flowing in and while it's kicking the calcium out. And so you'll note that I'm having a 3 to 2. Don't forget this is 2. So I'm having a 3 to 2. So again, I'm having a net movement. Every time this pump spins, I'm having a net positive going into the cell. And that's why this is in the below the baseline here. Because remember I said, if it's below the baseline here, remember we talked about the same thing here, that means I'm having a net positive charge moving into the cell. And that's exactly what's happening with this NCX pump. So this is the way you rectify the situation in terms of getting the calcium out. Now, one of the cool things about this pump, and we're going to see this later on, is that this is a reversible pump. So as long as I have a nice gradient of sodium, electrical forces and gradient forces, the sodium is going to be coming in. But if I were to have a different configuration where, say, the membrane is somewhat positive, now I'm losing my driving force of sodium coming in, this pump can actually reverse and can actually, the calcium, okay, I will say then the calcium will go in and it will kick out 3 sodiums, which is kind of cool. So this is a reversible pump. Now, what determines what direction this NCX pump will go? What will happen? It's basically a function of the membrane potential, and that will determine whether my energy is coming from the sodium wanting to flow in or the calcium wanting to flow in. But in this situation here, it's all about that configuration there. So now that raises another question. Okay, so I've taken care of the calcium, so I now know how to rectify the calcium that flowed in to kick it back out. What happens to all the sodium and the potassium? Because I'm having a potassium flowing out of the cell, and I'm having sodium flowing into the cell with these funny channels in this delayed rectifying channels and these acetylcholine channels. Well, don't forget our good old friend, my sodium potassium ATPase pump. Sodium, and then potassium here. And of course, you got your 3 sodiums and the 2 potassiums here. But this is going to burn energy, so this is going to be my sodium potassium ATPase pump. So that pump is not in this diagram, but this is going to handle the sodium-potassium gradients, trying to, again, realign the situation so that I don't run out of potassium and run out of sodium. So between the sodium-potassium ATPase pump and the NCX pump, they're the ones that are going to be making sure that the concentration gradients of these 3 very important ions are kept in the appropriate levels so that this system can continue to do what it does. Okay, so on the next page, I basically have everything I talked about laid out here for you. Maybe the wording is a little differently, but these are basically the points I've just talked about. So this is more of a summary. In case you want to go back and read through it, I advise you to do that in case I forgot something. But anyway, so this is kind of a summary of what's going on here. But this is really, I just find absolutely fascinating that you can, if you have the right kind of channels, that you can orchestrate this lovely dance of these electrolytes or ions relative to these channels that are opening and closing in beautiful rhythm of each other. Okay, so we will pick up on the next block next time. This section, I want us to consider the concept of automaticity, and then I'm also going to be introducing some additional vocabulary as well. So the general idea, the generation of pacemaking stimuli, automaticity, again, auto meaning self-generating, of course. So you have action potentials from the SA node, and they'll start a sequence for both the atria and the ventricles to contract in a well-timed, coordinated fashion, optimized for the pumping of blood. What do I mean by that? What I mean is that the blood will flow into the atria, and of course we have the atria here. Blood will flow into the atria from the non-lung part of the body and then the lung part of the body. And of course, as we said earlier, most of it will just flow directly into the ventricles. But when we have an atrial contraction that just pushes that additional amount of blood into the ventricles, you wouldn't want the ventricles at the same time to be contracting. That would be self-defeating. So you want the atria to contract first, and then you want the ventricles to contract. So timing is everything. So when you have a action potential that is being generated from the SA node, I'm wanting that action potential to go through the cardiomyocytes in the atria for contraction, but I'm not wanting this signal to go so fast that it would go to the AV node and then to the ventricles, causing the ventricles to contract at a time that is not in sync with the atria. I want the atria to contract, then I want the ventricles to contract. So part of the job of the conducting system is to make sure that that timing is optimum for pumping of blood. So again, it has to be well coordinated. So there are other areas of the heart that can potentially have automaticity qualities as well. And as we may have mentioned, that you do have latent pacemakers throughout the heart, and the dominant pacemaker is going to be the one that is pacing the fastest and is again going to suppress, in a sense, the other pacemaking cells. But I want to get into this and just kind of talk about how all of this works together. So again, these areas of the heart we would call automaticity foci. So automaticity foci is just basically an area of the heart that has the ability to generate its own action potential. So normally, the only automaticity foci is going to be your SA node. But the others are out there, they're just being suppressed. So if you have another area of the heart that starts generating its own action potentials, then that would be considered an abnormal occurrence, because then that then messes up the timing of the depolarization of the various areas of the heart. So that was not something we want. We would consider that to be an abnormal occurrence, which again is going to lead to some type of arrhythmia or dysrhythmia. These automaticity foci can occur anywhere in the atria, could be occurring in the ventricle. Again, lots of options there. And again, as we said, they normally don't generate pacemaking stimuli. They're going to be suppressed by the AV node, and then would be suppressed by suppressed by the SA node, and then suppressed by the AV node action, as the AV node is going to pass that action potential that originated in the SA node onto the ventricles. Under certain condition, though, these automaticity foci will spontaneously depolarize, generating an action potential. And again, as we said, when that happens, then that could lead to a type of arrhythmia or dysrhythmia. So when this happens, most of the time we could say that the focus has become, or the focus has become irritable. So I'm hedging on that because you can have a automaticity foci that would generate an action potential when it's not supposed to, and you would not consider it to be irritable. but many times they are irritable. So the difference between irritable and non-irritable is a function of cell biology, so I'm not wanting to get into that. First of all, it's not well understood at all, but we're just going to basically leave it as this, that many times a focus can become irritable, then it's going to start generating action potentials. But there are times when a focus can generate an action potential inappropriately and it not be irritable. Just different cell biologies are underlie that, and that's all I'm going to say about that. So when we're talking about irritable foci, what are some things that could trigger a focus to become irritable? Now, when it becomes irritable, by definition, I'm meaning that it is now going to be generating action potentials that are going to start depolarizing the muscle tissue around it, etc. And when it does, again, you've got a problem with an arrhythmia. So multiple things could affect or generate or cause a focus to become irritable. This is not an exhaustive list at all, but you could have things that you're taking in. It could be caffeine, it could be amphetamines, it could be cocaine, it could be drugs, such as drugs that work on your beta-1 receptors. It could be epinephrine. It could be, involving the sympathetic stimulation. It could be other drugs, digoxin, which we'll talk about later. Ethanol could do it. Hyperthyroidism, hypoxia could do it. Hypokalemia could do it. Stretching of the heart could cause a focus to become irritable. Myocarditis, an infection of the heart, could cause a focus to become irritable. Mitral valve prolapse, we'll talk about that later. Again, that's another way of another mechanisms for stretching the heart. Point being is there are lots and lots of things that can cause various foci in the heart to become irritable, meaning that they're going to start generating their own action potentials leading to arrhythmias. And again, we got multiple sections, multiple lectures coming on arrhythmias. So right now I'm just kind of introducing the concept to you. As I said, there are lots of areas of the heart that could possibly be generated or could become irritable or also generate their own action potential, even if it was not irritable. So we will call these latent pacemaker cells. Okay, so latent pacemakers. Okay, and latent meaning they're not doing anything. Now, if they start doing something, then they become automaticity foci and they're generating arrhythmias. So, I mean, they could be there, could be there, could be there, could be there, could be there. You got all these areas of the heart that are normally suppressed, but they could, for whatever reason, start generating their own action potentials. So here comes some more vocabulary for you. So we could say that the SA node overdrive suppresses all automaticity foci. Overdrive suppression. So overdrive suppression means that the faster pacemaking cell is suppressing all the other latent pacemaker cells, which is why they're called latent. So we're going to have to get used to that term, overdrive suppression. Okay, and so the fastest one is going to dominate, and of course, normally the fastest one is the SA node. Now, if the SA node is for some reason not functioning properly, in other words, say it stops generating an action potential, or it may generate action potentials but at an abnormally slow rate, then you open yourself up for one of these other latent pacemakers to start generating their own action potentials because they're no longer being suppressed or no longer under overdrive suppression. So when that happens, then we could call this an ectopic focus. You understand the concept of ectopic like an ectopic pregnancy. Ectopic meaning occurring at a place where it's not supposed to occur. So I have an area of the heart that's generating its own action potentials, automaticity foci, where it's not supposed to do that. So we would say it's an ectopic focus, and that it will in fact escape overdrive suppression. So when we hear the term escape rhythm, that's another cardiology term, escape rhythm, meaning it is escaping overdrive suppression and doing its own thing. So if you had a focus, an ectopic focus in the atria, and it was generating its own action potentials, we would say then, and the atria then is beating to the rhythm of that ectopic focus, then we would say that the atria is having, we call it atrial escape rhythm. In other words, the rhythm of the atria is being generated by some focus that is other than the SA node. So atrial escape rhythm. You could have a ventricular escape rhythm as well. Okay, escape means it is no longer being suppressed. If the depolarization signal from the atria does not make it to the AV node, and the AV node is going to be at the AV junction, so there's my AV node there, AV node. Okay, right there, that's my AV node right at the bottom of that right atrium. And so, what we've said before is that the sinoatrial node or SA node will depolarize the atria, and that signal will make its way to the AV node. And the AV node's job then is to transmit that wave of depolarization through to the ventricles, but it will slow it down a little bit because, again, we want to make sure the timing is correct, so we don't want the ventricles to contract too quickly, such as trying to fight the pressure generated by the atrial contraction. So timing is everything. So the AV node is going to be communicating that action potential through it into the ventricle. So at this point, the AV node is not generating its own action potential. It is not functioning as an automaticity foci. Again, it has that ability to do that, but it isn't. All it's doing is just communicating, responding to the action potential that's coming from the atria so that it can then, in a appropriate timed fashion, communicate depolarization to the ventricles so the ventricles can contract. The AV node's normal pacing is about 40 to 60 beats per minute. So again, it is also, when things are normal, a latent pacemaker entity, and left into its own devices, that's going to be about the rhythm that it will do, which is slower than the SA node. But again, the SA node and the depolarization from the SA nodes is suppressing, overdrive suppressing the AV. But if for whatever reason the signal coming from the SA node, if it doesn't make it to the AV node, then if the AV node is no longer going to be overdrive suppressed, and then it will start its own beating pattern, and then it will generate an action potential, and it will, on its own, cause the ventricles to contract. So if you have that, then we would call this a junctional escape rhythm. Junctional meaning AV junction. So in cardiology speak, if the patient has junctional escape rhythm, what that means is that the AV node is generating its own action potentials to depolarize the ventricles, causing the ventricles to contract, and they are not in sync, they are not responding to the SA node. So in general, an escape rhythm is any rhythm other than a rhythm originated from the SA node. So a junctional escape rhythm would be just a kind of escape rhythm. One other thing that I want to mention here is that you can have an atrial escape rhythm, of course, as I mentioned earlier. Sometimes the focus, the ectopic focus of an atrial escape rhythm will be in just say one area. So let's just say we'll make it brown. Okay, I'm just picking something out. So maybe that area right there, that's the one that is generating a depolarizing event. Maybe it's irritable, and so it's doing its own thing. So it's going to be causing the atria to contract because it's going to emanate through there, and it's also going to be communicating to the AV node. But again, this is going to be an atrial escape rhythm. But sometimes what will happen is you'll have a period where an area will be functioning as a pacemaker, and then another area will generate a pacemaker, and then that area there will just kind of go away in terms of no longer generating the pacemaker, and then it will take over for a while, and then eventually then maybe it stops, and then another area will take over. So when that happens, we would call that a wandering pacemaker. And the name's pretty descriptive. It's just the entity, the part of the heart that is generating the rhythm is just kind of wandering around. So in a sense, it's tag teaming. One area of the heart will generate a rhythm, then another area of the heart will generate a rhythm, another. So it's just wandering around. So you hear that term, wandering pacemaker. Okay. So other things to be considered, an automaticity focus is overdrive suppressed if it is regularly depolarized by the pacing rate of another focus faster than its own. So I've already kind of said that. The fastest pacemaker is going to normally overdrive suppress, again, if things are going according to script. So the SA node suppresses other potential automaticity foci because the SA node is the fastest. But again, if an automaticity focus is not overdrive suppressed, regardless of the cause, it escapes to initiate its own pacemaking activity. In certain cardiopathologies, the automaticity foci are not subject to overdrive suppression, and again, we've just kind of talked about that. But I'm bringing that up again because there is another term for that, and we call that an entrance block. Okay? So what is an entrance block? An entrance block is the lack of suppression of automaticity foci by the depolarization of another automaticity focus. Okay, why do cardiologists call this block? So a way you can look at this, we could say that there's something about that focus. That focus is acting out now. That focus that is not normal. There's something about that focus such that the wave front's ability to suppress the focus is being blocked. Okay, so we can cartoon it out. Say we have an SA node here. Okay, and it's going to have an action potential, and that action potential now is just going to be a wave front. A wave of depolarization is going to be emanating throughout, in this case, the atria. And so you may have some other latent pacemaker, groups of cells somewhere in the atria called the green one there. So that's going to be my latent pacemaker. I'll go LP there, latent pacemaker. Again, that wave front normally suppresses it, but there's something about these little guys right here that they are no longer being suppressed, so that there's something about the focus such that the suppressing wave is being blocked, such that now it starts generating its own action potential. So we would say then that little area there is a point of entrance block. In other words, the suppressing wavefront is being blocked such that it is no longer suppressing that area here, and now it is beginning to generate its own action potential. Lots and lots of things can cause an entrance block. Now again, just to be redundant, just to make sure we're clear, when a cardiologist talks about an entrance block, what we're talking about is a pacemaker area of the heart, a latent pacemaker area of the heart is now beginning to do its own thing. It's beginning to generate its own action potentials. We'd say that's an example of an entrance block. Loads of things can cause an entrance block. One of the common things could be you have ischemia. Maybe you have some type of issue, some coronary blood flow problems going to the heart, so it's not getting enough blood, enough oxygen, etc. So the tissue around the particular focus is being stressed, and the nature of that stressed tissue is such that when the wave front, the axial wave front comes through, because the area around the focus is maybe, again, undergoing ischemia. I got some ischemia going here. Now that wave front can't get through the ischemic part, and then all of a sudden that group of cells starts its action potentials. And the nature of the ischemia is such that the wave or the action potential coming from that group of cells that are becoming generating action potential, the wave can get through the ischemic area, but the wave from the SA node can't get to it. So, again, you got a problem. So, ischemia could cause an entrance block. Infarction could cause an entrance block. So maybe instead of that area being having stress in terms of ischemia, maybe now it's being infarcted. Okay, it's dying. Same thing. The wave front of the axial potential from the SA node and the surrounding atria or atrial tissue can't penetrate it, allowing that then to create its own. It's no longer being overdriven, suppressed, so it can generate its own axial potential, and there's something about the tissue that will allow that axial potential being generated to go through that ischemic or that infarcted tissue and then cause a problem in terms of some type of arrhythmia. Again, not exhaustive. Again, lots and lots and lots of things can cause this to happen. So the ischemia, the infarction is just an example. Again, as I said earlier, drugs could do it. Caffeine could do it, etc. So lots and lots of things can cause an entrance block. Okay? If there is an entrance block, the leading particular focus, entrance block leading the particular focus to escape, in other words, now it's going to be generating an action potential, causing tissue to contract, whether it's coming from the atria or the ventricle, one of the ventricles, that focus is said to be parasystolic. So, parasystole is a type of arrhythmia where an ectopic focus or ectopic foci are being depolarized, I said that messed up. Let me try that again. The parasystole is a type of arrhythmia where ectopic foci are depolarizing the atria or the ventricles in addition to normal beating. So this would result in an added beat. Okay, so consider this. Suppose that you had a normal sinus rhythm. Okay, so maybe you're going along at 70 beats a minute. So I'm going to scribble an ECG. It's not going to be accurate, but I'm just trying to make a point here. It comes along, you got a beat, and then another beat, and then another beat, and then another beat. Okay, so I got beat, 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 beat. And suppose this is, 70 beats per minute. So imagine now I have a ectopic focus, and it starts generating its own beat at its own time. Now, the timing may be slower than the SA node, or maybe faster than the SA node, who knows? But what will happen is that in addition to a normal beat, all of a sudden you'd have maybe a beat there, and then a beat there, and then a beat there. So those would be your ectopic beats. Those would be an example of a parasystole. So I'm having normal sinus rhythm, normal beating, and then overlaid on that is going to be another area of the heart that is going to generate an action potential at whatever pacing it is. And so that rhythm of beat is going to be overlaid on the normal beat. And so you're going to actually see extra beats. So this would be classic parasystole. So if you hear a cardiologist saying, yeah, the patient has parasystole, what that means is that in addition to the normal sinus beating, you're going to have another focus somewhere that is also causing the heart to depolarize as well. And so those two beats would literally be overlaid each other. So you have a lot of different vocabulary that kind of means the same thing. And so what I really kind of need for you to do is to write these terms down, write the definitions out, and just kind of go over them and over them so you get comfortable with these terms, because a lot of these terms kind of overlap. Because if I'm talking about parasystole, then I'm talking about a focus that's not overdrive suppressed. Then I'm also talking about an entrance block. So they all kind of mean similar things. So I just need for you to, again, just get used to employing these terms. So one last point before we close this out. Since I've already talked about an entrance block, if there's an entrance block, you can probably guess that there's also a concept of an exit block. And I just want to toss that out here before we leave. An exit block is defined as autorhythmic cells that generate an action potential, but the action potential cannot exit that focus. So an example would be a sinoatrial exit block. Okay, so again, look at those terms and try to understand what that really means. Sinoatrial meaning SA node. So one quick point about the SA node. Of course, we saw the SA node, up here, okay, up near the vena cava. So the SA node, it's a group of heterogeneous cells. They're not all the same type of cells. Again, they have that ability to auto-generate. So you have the no resting membrane potential, all that stuff like we talked about in an earlier lecture. But generally, the SA node can be divided up into two regions. The interior region we call P cells. Okay, so I'm going to go P cells there. And then an outer region of the SA node, and those have T cells. Okay, they're just different cell biologies involved. And then, of course, out here is going to be my atrial tissue. All right? So what happens with the SA node is they're going to generate an action potential somewhere in the P cell collection, in the interior region of the SA node. And then when that action potential happens, the wave of depolarization will then go through the T cells. And then the T cells, if it allows it to go through, which it normally will then cause, of course, an action potential in the atrial part of the heart, the cardiomyocytes there. And so that's when things are working normally. What can happen is that you can have a generation of an action potential within the P cells, but there's something about the T cells that will not allow that action potential wave to make it through. Therefore, the P cells are working, but the T cells aren't letting that action potential wave front make it out. Therefore, you're not depolarizing the cardiomyocytes in the atria. So when that happens, we consider that a type of exit block, and we would consider that to be a sinoatrial exit block. Again, what that means is the P cells in the SA node are doing their thing. The problem is the surrounding T cells are not allowing that wavefront to get out of the SA node. Another kind of side point here, the area that generates a sinus rhythm, it's not all the P cells doing the same thing. You may have an area of P cells, and that be the primary generator of the action potentials, and then it might move over here, and then it might move over here, and then it might move over there. That's fairly normal. So within the P cell region, it might, it kind of goes through different places. Now, as far as looking at this from, the atrial contraction, it doesn't make any difference. you really don't have any way, unless you're undergoing experimental conditions, you have no way of knowing if the particular cells of the particular P cells, a subgroup of them, generating an action potential, then another subgroup generates an action potential. You can't tell if they're moving around or not. You can only see that in experimental conditions, but they have discovered that that's how that works. Anyway, so the exit block means, again, you have a generation of an action potential, but it can't leave the node that we're talking about. In this case, it would be the SA node, so we would say that's a sinoatrial exit block. Okay, just work on this vocabulary because we're going to be using these words over and over and over again in future lectures. And if you go into medicine, you're going to be using these words all the time when you're dealing with your patients discussing cardiology issues. Okay, see you next time. This section, I want to consider the conduction system of the heart. We had talked earlier about the SA node and the AV node, but how do those structures communicate with the rest of the heart? So that's what I want to talk about now. So I think the first thing we'll look at is going to be the anatomy of the atrial conduction system. Of course, we have our SA node sitting up there. We have what is called internodal tracts. And these internodal tracts are thought to be specially arranged cardiomyocytes that are, in fact, contractile, but they have the ability to conduct an action potential propagation at a faster rate than a regular cardiomyocyte would do. And the thinking is that maybe it has to do with the orientation of these cardiomyocytes. They seem to be aligned a little better for a more efficient conduction velocity, and they can run about twice as fast as the wave front would progress through regular cardiomyocytes. So, of course, this is the right atrium here. And the left atrium here. And if the SA node is in the right atrium, so it is going to depolarize, emit an action potential that will create a wave front that will progress through the tissue. What's going to happen is that the action potential needs to be communicated to the left atrium. And so you have a structure called Bachmann's bundle to the left atrium, or also you would be calling it just Bachmann's bundle. And this is the main path, it is thought, through which an action potential will then communicate with the left atrium, thereby allowing the left atrium to have a wave of depolarization from cardiomyocyte to cardiomyocyte. There are other minor pathways that will connect the SA node to the left atrium. I'm not going to name them. They all have names, but it's not worth, because they're fairly minor. It is thought that the major one is going to be Bachmann's bundle. You have the propagation from the SA node, and again, it will be communicated to the local cardiomyocytes in the atrium, but you do have these internodal pathways that will more rapidly communicate the action potential to the AV node. And so you have three major ones of those. One would be the anterior internodal pathway of Bachmann, and that would be one right there. The middle internodal pathway, Winkelbach, and that would be that one there. and then the posterior internodal pathway of Thoral, and that one would be there. And again, the idea is that when the SA node depolarizes, and again, it will communicate to the cardiomyocytes of the area, but you do want to be able to get to the signal to the AV node in a little more rapid fashion so that the AV node can do what it's going to do, which will allow that wave of depolarization to pass through it, but we'll elaborate more on that in a minute. So that's basically the outline of the structures. Here is you have your atrial internodal pathways. And again, these internodal pathways, these fibers are contractile. They're cardiomyocytes, but they just have some special quality that allows them to communicate things more quickly. As I had mentioned before, you have a timing. The timing between what goes on in the atria and the ventricles is important because you want it to be coordinated. You certainly don't want the ventricles to contract before the atria are finishing contracting. You want the ventricles to contract after the atria has contracted, push whatever blood it's going to push into the ventricles. Then you want the ventricles to contract. So timing is everything. What you'll see in the elderly is that you'll have some disruption or some compromise to these conduction systems that we're talking about. You know, we all have special arteries that feed the SA node, the AV node, and the other conductive tissue. But when individuals get older, you may have some problems with blood flow to the various regions of the heart. And so if you're creating ischemic conditions in a person and it's particularly affecting these internodal pathways or the SA node or AV node or some of the pathways we're going to talk about in the ventricle, it can be a real problem in terms of creating all kinds of arrhythmias. And we're going to talk about these various kinds of arrhythmias in coming lectures. But what can happen ultimately if these deteriorate is the only solution is actually put a pacemaker in so that the pacemaker then can generate the appropriate timing for heart contraction. We'll talk a little more on those later. We had maybe mentioned or you have heard of Purkinje fibers. Purkinje fibers are found in the ventricle, but I just wanted to remind you that there are no Purkinje fibers in the atria. Okay, those are only in the ventricles, and because Purkinje fibers are not contractile fibers. They are specialized fibers that have different cell biology qualities to it, but Purkinje fibers do not contract, whereas these internodal atrial pathways are contractile. Okay, so moving on to taking a look at what happens in the ventricle. Again, first, let's take a look at this diagram showing the conduction of both atria ventricle. So what you have here again is your SA node, and these are going to be internodal pathways. And looks like maybe, okay, they kind of left one out over here, but they left it out because it's not the one that is communicating with the AV node, so I can see why they would leave it out. So you have those, you have the AV node, and then after you have the AV node, right below the AV node, you have what is called the bundle of His. Okay, and then you have after that the bundle of His is going to bifurcate into the left bundle branch, the right bundle branch, and of course this is the septum of the heart. So they're going along here, then we'll go towards the apex of the heart. You got other branches named off of these, particularly the left bundle branch that we'll talk about later. This is an oversimplified drawing, but we'll name some of those later. But they hook around, and then at the very end point where you have the interphase with the cardiomyocytes, now we have the Purkinje fibers, and that's the last interphase before they communicate the depolarization wave to the actual cardiomyocytes themselves. One of the things that's interesting, though, is to get a sense of timing or velocity. One cardiology word you're definitely going to want to know is dromotropy. Okay, dromotropy has to do with the conduction speed through tissue. You could have dromotropy in terms of axons and neurons, but in this context here, we're talking about the speed of conduction through heart tissue itself. You could have dromotropy in regard to skeletal muscle. In other words, if you have a wavefront, a depolarization is progressing through tissue, what's the velocity of that? And we call that dromotropy. So what that also means then is if you're giving your patient a drug and the drug has a positive dromotropic effect, what that means is there's some quality in that drug that is going to alter the cell biology of the tissue in question that will cause the conduction velocity to increase. Of course, you could have a drug that would have a negative dromotropic effect. That means it would slow the conduction velocity down. And again, as you would expect, because you know the heart has sympathetic and parasympathetic effects, the sympathetic effect, and we'll talk more about this later, but one of the things the sympathetic system is going to do is going to be causing to have a positive dromotropic effect. It's going to speed many things up, one of which is the conduction velocity. Okay, so actually just to get an idea in terms of some velocities, we're talking about the conduction velocity. If we're talking about a wavefront progressing cardiomyocyte to cardiomyocyte to cardiomyocyte, typically we're talking somewhere in the range of maybe 0.7 meters per second. Okay, so that's going to be cardiomyocyte to cardiomyocyte. Okay, again, there's a range here, so I'm just kind of picking something close. So call it 0.7 meters per second. The velocity of the internodal pathways is almost double that. So we're just going to call that, call it 1 meter per second. Again, there's a range, but I'm just trying to be simple with you. So 1 meter a second. So what you can see here is that the internodal pathways are a little bit more, have a little greater velocity of conduction compared to cardiomyocyte to cardiomyocyte. I had mentioned earlier that one of the jobs of the AV node is to slow things down. So you have an action potential emanating from the SA node, and so that would be, again, called a sinus rhythm. So you have the depolarizing event through cardiomyocyte in the atria, but it also is going to quickly make its way through to the AV node, complements of the internodal pathways. When it goes into the AV node, again, at this point, the AV node's job is not to generate its own action potential, but it is simply being depolarized by the signal from the SA node. So it is going to be generating an action potential, but the timing of it is going to be set by the SA node, so it's not generating its own action potential at its own rhythm, again, because it is being suppressed, because the SA node, of course, is the quicker node. So the AV node will convey or have its own action potential, but it's going to be triggered by the incoming signals from these internodal pathways. And interestingly enough, the velocity through the AV node is 0.05 seconds. Again, that's just a generality. Excuse me. Mess that up. Try that again. That's going to be meters per second. There you go. So the thing that I want to impress you with is that we're having a wavefront going through these internodal pathways at 1 meter a second. Then it hits the AV bundle, or excuse me, the AV node, and it slows it down to just a fraction of that, like 1/20th of the velocity here. More than 1/20th. No, it'd be 1/20th. Point being, it's a lot slower. Okay, it goes from 1 meter a second to 0.05 meters a second. So big slowdown, again, it all has to do with the timing. So then it's going to be going through the AV bundle, or the bundle of His. And let me see what different color here because it's getting a little busy. So the velocity in the bundle of His, right there, that is going to be about 1.5 meters per second. Okay, that's even faster than internodal pathways in the atria. And so then it's going to be making its way through the left and right bundle branch, and dig this, now it's going up to 3 meters per second. So again, significantly 3 times the velocity is what you had even in the internodal pathways in the atria. So things happen very quickly through these left and right bundle branches, and then of course their endpoint. And then they get to the Purkinje fibers, and again, we're probably clipping at about 3 meters per second. And then again, in the ventricles, the Purkinje fibers are the last interface before it gets to the cardiomyocytes that are going to contract. And then once it does that, now we're back to about 0.7 meters per second. So this just gives you a sense of the velocity through which these various systems are working. I'm not really interested in you memorizing these numbers, but I am interested in you knowing relative velocities. So it'd be kind of nice to know that the conduction system in the ventricle is roughly 3 times in the internodal pathway. It's kind of nice if you knew that the AV node slowed significantly relative to the other velocities we see in this system. So again, don't get hung on the numbers, but do have a sense of relative speeds with these various structures. So anyway, that's kind of cool, I think. Okay, you recall we talked about the sinus node being not just one big blob, but you have P cells and then T cells, and I'm leaving stuff out. It's actually more complicated than that, but my point there is that it is a heterogeneous group of cells, and they have various things going on in them in terms of how they work together. Well, the AV node is the same thing. It's not just one blob of cells. You have different regions. So here's a nice drawing here of the AV node. So here we have the internodal pathways, got 3 of the major ones coming in, and they're going to be interphasing with the AV node. Now the AV node itself, if I could, let's go here. So the AV node itself is going to be this part right here. Okay, so that's my AV node. So it is made of multiple regions of specialized cells. So in the beginning here, we have what is called an AN region, and this is considered a transitional zone. And the AN is, again, going to be the first thing that the pulse or that the wavefront is going to be seeing. And so it is going to be, and again, it's coming at a high velocity, and so it will begin to slow down the conductions through there. Then you have the end zone, and the end zone here is going to be that middle area. Now, that's the business end. That's the one that really, really slows things down. So by the time we get to the end zone, again, now we're talking, 0.5 meters per second. So things slow down greatly through that. And the other thing, too, with this is that you have a quality in the AV node, and it's called decremental conduction. Now, I have that written out here for you there, decremental conduction, a term that you'll want to be familiar with, because it's important for the function of the AV node, and we're going to return to that concept later, but let's just define it for you now. So one of the important properties of the AV end node is a decremental conduction. And what that means is that the faster, don't say faster, the greater the frequency of action potentials coming into it, the slower it will transmit the action potential frequencies. So in a sense, it puts the brakes on something. So if I'm clipping along at at a potential, say, call it just your standard SA node rhythm, sinus rhythm, and it's say 70 beats per minute. And then all of a sudden, if the timing of the atria goes to 200 beats a minute, then what's going to happen is that AV node is not going to convey necessarily that for 200 beats per minute. In other words, it's going to put the brakes down and not allow that frequency to be transmitted to the ventricles. This is kind of a safety thing in the sense that it's protecting the ventricles from the atria. And imagine if the atria were depolarizing at some incredible pathological frequency. You will want that very high abnormal frequency to stop at the atria. You would not want that frequency to be going into the ventricles, because you can survive if the atria contracts at a crazy high rate, as long as the ventricles don't do that. Because remember, when the blood comes into the heart, most of the blood makes it to the ventricles anyway. But if you were to have the ventricles to contract at a crazy high speed, that would be in line with the crazy high speed of the atria, then you're going to basically stop the pumping of the blood, because the ventricles are not going to have time to open up, relax, and fill with new blood. So it literally does save your life. And so this is, again, called decremental conduction. Again, we'll do more on this later, but if you have an atrial flutter, which is crazy high frequency, or if you have a fibrillation, which means you're not having contraction at all, it's just quivering, but sending extremely rapid numbers of axial potentials to the AV node will actually stop that from happening. So again, it's a preventative and it's a life-saving thing. So there we have the in region. And as we go through, the next one is going to be the NH region. And of course, the H stands for His. So now we're into the bundle of His region here. And then it's going to be moving from that, again, on into the right and left bundle branches. One of the other things that I want to point out, and again, a very important concept here, is that you have connective tissue, fibrous tissue, that's separating the atria from the ventricles. The reason that is there, or one of the reasons that is there, is that fibrous tissue cannot convey an electrical impulse. So you have a wave of depolarization through the atria, but by the time it gets to the bottom of the atria, and now it's in contact with the part of the atria that's going to the part of the atria that's in contact with the ventricles, that's fibrous tissue, and so the wavefront stops there because that's not depolarizable tissue. So what that does is that insulates the atria from the ventricle. It also then forces any type of electrical conduction in terms of axial potential propagation to only get from the atria to the ventricle via this AV node. Now, we're going to find out later when we're doing some arrhythmias that there can be other routes from the atria to the ventricles, but that would be considered a pathology, and we'll talk about that later. But my big point is you have this fibrous tissue here that keeps the electrical activity of the atria from getting into the ventricles and forces any type of signal through this the AV node. So the bundle of His, again, we'll go through here, and then go here, and then here is where you're going to have your left and right. You have the bifurcation of the left and right bundle branch. All right, a couple of the things that I want to talk about here just in general, and that is that what goes on in the AV node, or this complex that we're calling the AV node, is poorly understood. So some of the points that I'm making are more general, but there's a lot of ambiguity in terms of mechanisms and cell biology and how this works that people are still working on. But let me show you a couple of things that's fairly well established. When you get into the AV node, it is understood that there are actually two different pathways through the AV node. There is a fast pathway, and then there is a slow pathway. This is in the literature known as dual AV nodal physiology. So you got fast and you have slow. And they have their different characteristics. So normally, if you're in a sinus rhythm, the signal is going to go through the AV node through the fast pathway. The fast pathway, it can get through more quickly, but it has a longer refractory period. Now let me remind you what a refractory period is, because we talked about this when we were doing the neuro part of the course. But remember, when you have an action potential and you have those voltage-sensitive sodium channels opening up, and it has to depolarize before, or repolarize before they become active again. So you have a period where you have an action potential, and regardless of stimulus, you cannot have another action potential until those voltage-sensitive sodium channels are ready to go again. And so we call that a refractory period, an absolute refractory period. Well, you have refractory periods in the heart as well, and again, we're going to elaborate on that more later. So these particular cells that make up this fast pathway, because of their cell biology, the channels opening and closing, numbers of channels and things like that, they're going to have a longer refractory period. The cells are also longer, so you can see them, in histological sections being a little longer compared to some of the others, and they're also larger with diameter, which again reduces resistance. So it sets itself up for being a quicker pathway for the action potential, except the refractory period is longer. The slow pathway has a shorter refractory period. The cells are shorter and they're smaller diameter. So again, because of the smaller diameter, and then also because of change in cell biology, they tend to be more slow. So the reason that these two pathways are there, so they think, or the scientists, is that this may feed into the decremental conduction quality of the AV node. So as long as things are normal or near normal, the action potential will go through the fast pathway. But if you have a frequency that is, again, into the high frequency range, the AV is going to start pushing back and slowing things down in terms of communicating what's going on in the atria to the ventricles. And it is thought that the slowdown is going to be that you have, because of these longer refractory periods, can't handle the frequency that's coming from the atria, particularly if it's very high frequency. So it becomes more and more difficult to get a signal through the fast pathway. So that means the signal has to go through the slow pathway, but the slow pathway is slower. So the faster the frequency, the more you depend on the slow pathway, the slower the conduction. And again, that is thought that may be what is going on with this decremental conduction as well. So again, the interaction between the fast pathway and the slow pathway is complex, not well understood, but somehow they play off each other, modulating the speed with which an action potential from the atria can make it into the ventricle. One other thing that I wanted to point out as well in terms of a quality of the AV node, and that is it will allow an action potential to progress from the ventricles, from the atria to the ventricles, but it will not allow a retrograde signal. In other words, you can't have a depolarization in the left or right bundle branch. Let's go back up here. In other words, if I were to have an action potential right there, the action potential would go in that direction there. It might go this direction here, but it can't go through the AV node. So again, that is a protective type of arrangement, such that if I have something going on abnormal, along either the bundle of His or the right or left branch or any place in the ventricle, I cannot have a action potential signal that would actually cross back through the AV node and make it to the atria. So that's just one more level where the atria is insulated from what's going on with the ventricles. So again, you have two qualities that are important clinically with the AV. You got the decremental conduction deal. Again, the faster the frequency, it's going to start slowing down the conduction through the AV node. And then the other is that the AV node doesn't allow an action potential to go in reverse. One other thing before we end. We're going to see this dual AV nodal physiology, the fast and slow pathway, and when we get to one of the arrhythmias called AV NRT. This is the AV nodal reentry tachycardia. This is a type of tachycardia, and again, fast beating of the ventricle that is abnormal, of course, and it actually is coming from the AV node, and that's what it's called clinically, and we're going to talk about that later. But again, it has to do with this dual pathway, the dual AV nodal physiology, or these two pathways, and sometimes something goes wrong in the AV node, that interaction is abnormal, and so it can then start generating what is called a reentry current that can happen very quickly and cause abnormally fast action potential signals. They're going to be going down into the ventricle. Again, we're going to elaborate a lot more on that later because you have no idea what reentry is, but I have a whole little block of lecture on reentry, and you'll understand it better then. Okay, so that ends this section, and so we'll pick up next time. I want to turn our attention now to the contractile cardiomyocytes, and these are striated muscle tissue. You probably already knew that. Striated meaning that you have the I bands, the H bands, the A bands, etc. So the structure of the cardiomyocyte that is contractile internally is somewhat similar to what you saw in striated or skeletal muscle, so that you have your actin, you have your myosin, your S1 head, and the ratcheting action with the binding of calcium and such. So all of that is very similar, so I'm not going to rehash that part of it. So if you need a refresher, I'll just encourage you to go back and review your skeletal muscle lectures and notes. But there are a number of distinctions between the cardiac muscle, contractile muscle, and the skeletal muscle. The skeletal muscle, as you'll recall, is not made of discrete cells, but is made of a muscle fiber. So recall that you have the nuclei are on the periphery, and the fiber is a functional unit. Well, when it comes to cardiomyocytes, they are discrete cells. So what you have here, and you can see the nuclei are in the center, and you also see from the cartoon that the cardiac muscle are not little simple rectangles. They have a branchy pattern to them. The reason they branch is that enables for one cardiomyocyte to be in contact with a greater number of neighboring other cardiomyocytes. So the branching pattern is there for a reason. Another distinction that you see in the cardiomyocytes that are contractile is that you have what is called an intercalated disc. And so you see the little intercalated discs here, and here's just a zoom one. So there's your intercalated disc there, and it's just a way for one cardiac muscle cell to interface with the other. So let's take another look at the intercalated disc and see what is making them up. So I've already kind of drawn out two cardiomyocytes, cell 1 and cell 2. And so I'm going to draw several structures here. So one structure, I'm just going to go ahead and just draw here and here. And so we have these structures here, and then we have some intermediate filaments there. So I'm going to say intermediate filaments, and they're very strong cytoskeletal structures. And then we have some specialized proteins that are going to be connecting through here. So this first structure that I've drawn, we're calling a desmosome. And if you've had histology, then you know what that is. A desmosome is a structure that allows two cells to be strongly bonded to each other. So these two cells here, by virtue of the proteins in the middle, are connected to the cytoskeletal structure of each cell, and in particular the intermediate filament. And so this is what that is. The proteins in the middle here are called cadhedrons. Okay, so that's what those are. The next thing I want to draw is, I'm just going to draw it over here and here. Okay, and so this one, again, I have cadhedrons in the middle here, and then I'll just go maybe a different color, okay, here. And what I have here are actually microfilaments. So I'm going to go microfilaments. In particular, these are actin. So actin actually interfaces here, and so this is the actin that's going to be the beginning of the actin-myosin interface, so that when you have the ratchet action, it's actually going to draw the cells to be smaller. But again, you still have the cadhedrons in the middle to kind of keep it together. Another structure that you're going to see in the intercalated is going to be here. And these are going to be gap junctions. And these gap junctions are made of these specialized channels, okay, and the protein is called connexin. And they're made of 6 units. And what their characteristic is that they're voltage sensitive, and so given the appropriate voltage potential, they can open and close. When they're open, of course, creating a channel, which then allows ions and small molecules to actually go from one cell to another cell. So this is a mechanism by which one cell can exchange material into another cell. And what we're going to find out in a moment, that typically the main players here is going to be calcium and sodium. So they can go through that. I will also mention that there are many isoforms of connexin throughout your body, because the cardiac cells are not the only cells in your body that have gap junctions. You have them in smooth muscle, etc. So one connexin is not the same as another connexin, so forth, so on. Some will open fast, some will open slow, some will stay open longer, some will stay open shorter. So again, all kinds of variations functionally of the connexins. But the connexins basically make up the gap junction. So those are the main players here, and I'm left this other one open because I'm going to come back to it later. But this little area here, the widened area right next to the gap junction, is called the perinexus. And of course, the nexus is going to be the gap junction area. So this is a very important area. I'm going to talk about that in a moment. Okay. So the reason you have this is to, again, the intercalated disc is to give some integrity for the cardiomyocytes such that when they contract, they don't pull apart. Because what I just told you is that you have ions that are going to be flowing from one cell to another cell. And if you don't have these types of structures here that help the cells to adhere, then when one cell contracts, pulling from the other cell, it literally will tear the gap junctions apart. So the function of the intercalated disc is to strengthen the contact so that the cardiac cells don't literally tear each other apart and, of course, destroy themselves functionally. Now, let me make another point here. You'll recall when we were talking about neurons, okay, so neuron, axon, and then another neuron, axon, so forth, so on, that when you have an action potential, okay, and it is propagating, what you have here is a series of voltage-sensitive sodium channels that open, and then one trips the other one off and trips the other one off, kind of like falling dominoes. I've used that analogy before in terms of each group of voltage-sensitive sodium channels bringing the next group to its threshold, and then it opens up, so forth. And again, remind you that the voltage-sensitive sodium channels are double-gated, and a point that I'm going to make again later. There are many, many, many kinds of voltage-sensitive sodium channels. In fact, in cardiac tissue, there are at least a half dozen isoforms or different varieties of voltage-sensitive sodium channels. They all have their own characteristic. But then again, everything we talk about, there's different varieties of them. So just want to remind you of that. So you'll recall the challenge with neurons is you can have an active potential going from voltage-sensitive sodium to voltage-sensitive sodium, but when you want to go to the next cell, of course, action potential dies. So you know that you have a chemical synapse, releases neurotransmitters, and then communicate with the next cell down the line. So the connection here, again, a chemical synapse. You don't have the same challenge when it comes to a skeletal muscle fiber because it's all one fiber. So you have these voltage-sensitive sodium channels throughout the fiber. So once the potential gets going in the muscle fiber, the entire fiber can contract because it is a structural syncytium. So when you think about the cardiomyocytes, okay, and I just got through telling you they're not square or rectangle, but I'm going to draw them anyway just to make things simple. All right, you got that. So I have then voltage-sensitive sodium channels, right? So if I have an action potential moving in that direction there, when it gets to the end of the cell, the action potential is going to die. So you don't really have a way of, a voltage-sensitive channel tripping off this voltage-sensitive channel here. At least that was the theory. So you have to have another way of communicating the fact that one cardiomyocyte has depolarized, and how is it going to connect with the other. This is where the gap junctions come in. And so what you have here, these little gap junctions are so typically associated with the intercalated disc. Now, they don't all have to be associated with the intercalated disc, but a lot of them are. So intercalated disc, and so what's going to happen is when you have an action potential here, it's going to open up those connections, those gap junctions, and then typically you're going to have calcium and sodium flowing in, and the movement of the positive charge into the next cell is enough to bring then the voltage-sensitive sodium channels in that next cell to threshold, and then you have an action potential there, and so forth, so on. So you're actually hopping action potentials from cell to cell, but you see the critical role that the gap junctions play to be able to communicate from cell to cell. Another thing that I want to point out is because you have so many different varieties of connexins, the type of connection, its characteristic, can have a significant influence on the conduction velocity. So when I say conduction velocity, typically I'm going to be writing CV means conduction velocity. And we're going to find out in future lectures how important having the appropriate conduction velocity is as you have a depolarization of your cardiac tissue. Okay, so there's that. And on the next page, again, another cartoon, a prettier picture of the connexin and the gap junctions. So there's my gap junction there. I'm going to say G or GJ, gap junction here. And here is the perinexus. Again, it is that little space that is right next to the gap junctions. Now, both contractile and non-contractile cardiomyocytes communicate via gap junctions. But the intercalated discs are only found in the contractile part of the tissue. So you don't expect to find intercalated disc associated with the AV node, SA node, bundle of His, and the fibers that are running down the septum, et cetera, or the Purkinje fibers. So the intercalated disc appear when you have the contractile part of the heart muscle. Okay, so for many, many, many years, that was the convention for how one cardiomyocyte communicated with another cardiomyocyte. But there was always anomalies in the data that suggested that the story was more complicated than that. And it turns out it is. So I want to introduce you to another concept. And it is the concept of ephaptic conduction. Ephaptic conduction is yet another way for one cell to communicate with another cell when we're talking about voltage changes. So the way this works is, and I'll try to cartoon it out for you. Suppose we have a cell here, cell 1, and then over here we have cell 2. And suppose you have some type of depolarizing event in cell 1. So that means that the membrane potential, of course, has changed. And so the depolarization in cell 1 creates a change in the electrical field around it. And if you have cell 2 that's very close to cell 1, you actually could have the situation where the change in the electrical field can alter proteins in the adjacent cell. So more specifically, you have a depolarizing event in cell 1, and you have voltage-sensitive sodium channels in cell 2, and the fact of depolarizing in cell 1, changing an electric field, is enough to bring the voltage-sensitive channels in cell 2 to threshold. That's a different scheme. So here is a prettier cartoon that really presents kind of as a puzzle. So what we have here is our traditional gap junction, and so these guys here are going to be my connexins. And of course, they're going to open and sodium and calcium will be flowing through. So that certainly is one way of communicating a charge between two cells. Then right next to it, during the perinexus or the perinexus area, what they've discovered is that you actually have voltage-sensitive sodium channels. They're just sitting there, a certain type of voltage-sensitive sodium channels, and they're connected with some other proteins across here whose term is I'm not too worried about. And so this area here conceptually is called the cardiac EFAPs. And so let me walk it through. This was a curious type of experiment that they did, in the sense that when they experimented on this tissue and everything is normal, then the normal rhythms were occurring and everything was fine. But they were able to manipulate the cellular structure such that they now separated, made wider, the perinexus. And when they did that, they generated an arrhythmia. In other words, the heart did not work appropriately. The gap junctions were kept in place. Everything else was kept in place. All they did through some clever manipulation was widen the perinexus and things went sideways. So what that then suggested was there's something going on in the perinexus that doesn't directly involve gap junctions that's very important for normal functioning of a cardiomyocyte. And so what the other experiments were done, and what the evidence looks like now is that you in fact have ephaptic conduction, such that you have one cell here, cell 1, and of course over here is cell 2. So when you have a depolarization or an action potential of cell 1, this field here will actually open up, the change of the field will open up those voltage-sensitive sodium channels there, allowing sodium in that were in the perinexus space. And that in fact could also aid in bringing the adjacent cell to threshold. So what it looks like now is that you have a more complex system where you have an electric synapse, gap junction, working along with an ephaptic conduction process, which is really, really cool. So here is another cartoon. Now you can read the words down here, but it's kind of slick. So in A, what they're looking at is just the standard model for your gap junction. So connexin, and connexin 43 is a very popular one in the cardiomyocyte. There are other isoforms in the cardiomyocyte as well, but 43 seems to be one that's fairly common. So again, and this is cell 1, cell 2, so you have a depolarization, and then you have sodium coming in, and then that then in turn is going to cause the gap junctions to open, and when it opens, now you're going to have your sodium and your calcium flowing in that brings the next one to threshold, and so by the virtue of having sodium, calcium flowing in, you can see there that you're now having a rise towards the threshold for the cell 2, and of course that then is going to trip open that, and then you have your sodium rushing in, and here goes the depolarization in cell 2. So that's been for many, many years, that's the standard model. So what they're finding out now, though, in a B type of scenario, and go down here. All right, so now what we have is we have another scenario here. So this right here is going to be the perinexus. So this, that space right there is the perinexus. So now what you have, again, cell 1, depolarization. But with the sodium coming in here, now you're depolarizing that cell. That, in turn, is going to be altering the electric field. First of all, what you're going to have is a depolarization here, and then you're going to have sodium running in here. So the sodium is going to be opening up, so I'm going to have sodium leaving this perinexus area. So the mere fact that I'm having sodium leaving this perinexus area here, so I'm losing positive charge, and if I'm losing positive charge in this area here, that is going to, in turn, make this to be more positive. So this area here, because I'm having sodium channels, or sodiums, going through those voltage-sensitive sodium channels in cell 1, so this area here is becoming more negative. And if the perinexus is becoming more negative, then what that means then is that this area here is becoming more positive. And if it's becoming more positive, then it has the ability to bring that voltage-sensitive sodium channel to threshold, then allowing sodium to rush in, and then here we go, in terms of initiating an action potential in cell 2. So yet another way for the cells to communicate. Of course, this is not either or, so the latest thinking on this is that it is a combination of these two mechanisms. So we actually have a mixed mechanism. So we have ephaptic coupling and gap junctions that are going to be involved in the action potential propagation from cardiomyocyte to cardiomyocyte. Now, just a reminder, and I'm going to elaborate on this a little bit later before we close this up, that when we were discussing non-contractile cardiomyocytes, such as the cells in the SA node, AV node, bundle of His, or whatever else, the voltage-sensitive channels were not players. So your undulating action potentials came exclusively by way of calcium influx. So that is true through AV node, SA node, bundle of His, etc. So that is in contrast to a contractile cardiomyocyte, which is, we're going to see this very clearly in the next lecture, where the initial event depolarizing that contractile cardiomyocyte is going to be voltage-sensitive sodium channels, which will in turn open then L-type calcium channels. So the big trigger in the contractile sodium voltage-sensitive channels, where you don't have those in the non-contractile. Now, there is one exception to that. There's always an exception. One exception are the Purkinje fibers. Okay, the Purkinjes actually do have voltage-sensitive sodium channels that aid in their depolarization. Okay, so this is a kind of cool stuff in terms of it was a little more complicated than what for years they thought it would be, but this is, anyway, it's just neat, and so just wanted to make sure you understood how complicated these systems can be, and also how things change. Because I could not have given you this lecture 20 years ago, because they had no idea about that other mechanism. But in the past 10 or so years, there's been tons of data suggesting that this, in fact, is a very complex system in terms of how you communicate a voltage potential change from one cardiomyocyte to another cardiomyocyte. Okay, so we'll pick up next time. This section here, I want to talk about the action potential of a contractile cardiomyocyte. There are many channels involved. Various movements of ions are going to cause the membrane potential to move around on the cardiomyocyte my purpose here then is to give you kind of a summary in a visual way of what's happening to these various channels in movement of ions. Much of what I'm going to tell you working off this graph here I have written out for you on the following page. We did something similar when we looked at the various ion flows and channels, looking at, say, the SA node, which could also be is very similar to the the AV node, etc., except there we had no resting membrane potential. Well, in the cardiomyocytes, you have a resting membrane potential. One of the other differences is that in the undulating membrane potential of the pacemaker type of cells, it is the calcium that is the main driver in the initial depolarization. When it comes to the cardiomyocytes that are contractile in nature, it is the voltage-sensitive sodium channels that are the initial depolarization factor. And then the calcium comes in after that. So there's a difference between those as well. So what I've drawn are some red lines here to kind of help you visualize what's happening on these various channels as we go through the various phases of the action potential. So as we had in the pacemaker cells in terms of phases, so we have phases here as well. So we have phase 0, and phase 0 is going to be our depolarization phase. I'm just going to say dipole. Then phase 1 is going to be our early repolarization. Say repole. Then phase 2 is going to be our plateau phase. Whoops, backwards there. And then phase 3 will be our final repolarization. And then phase 4 is going to be our resting membrane potential. So now let's see what happens. Why is the action potential shaped this way? Well, we have our channels below here, and we have the little zeros here. So some of the shading is above the 0, some of the shading is below the 0. So when the shading is below the 0, so we'll go shading or shade below the 0. What that means is that inside the cell is becoming more positive. And if the shading is above the 0 line, that means the inside of the cell is becoming more negative. So that kind of helps you interpret. So the initial thing we're looking at is going to be our voltage-sensitive sodium channels. And again, remind you, there are many, many types of voltage-sensitive sodium channels, different isoforms, even within a cardiomyocyte. So the voltage-sensitive sodium channel opens, which allows then sodium to move into the cell, carrying its positive. And so that means as the flow, as it goes inside the cell here, the inside the cell is becoming more positive. Therefore, it's driving the membrane potential towards the positive direction. You'll recall that the sodium Nernst value is 50, 60-ish. It makes it up to 25, unlike a depolarization of a neuron, which makes it pretty much close to the Nernst value for sodium. It doesn't go that high for the myocardial site here. So, but it does make it near the plus 20. So it goes up, and again, you see this here, voltage-sensitive sodium channel. Well, there are other things going on pretty much at the same time. It depolarizes, And in addition to that, we have our L-type calcium channel. It is beginning to open up, and it is allowing calcium to flow in. So another thing that is, again, driving it northward. But this time what's happening is that the L-type calcium channels only open. Now they're opening in response to the depolarization of the voltage-sensitive sodium channel. So there's a little bit of a delay. But I'm still starting to get some calcium to flow in here. Now you'll note here is our T calciums. Now the T-type transient calcium channels, which this author puts in here, very minor, very, very minor. In fact, some texts won't even mention it, so they are there in a little bit trace amounts, but again, it's not that physiologically significant. But you'll note this is phase 1, I'm having early repolarization, which means I'm having something drag the membrane potential towards the more negative. Well, what's going on with that? Well, one thing going on is that I have here some outward rectifying potassium channels. Which means then, in this case, potassium is leaving. It's flowing out. So again, note that the shade is above the line, meaning this force here is wanting to make inside the cell to be more negative. So what I have here then between the outward rectifying potassium channel and then I'm having the L-type calcium channels opening up, I'm having potassium flow out, I'm having calcium flow in, but note what's happening to the membrane potential. It is going towards the negative direction, which means then I'm having more potassium flowing out than I am charge coming in. So who's winning the battle there? I'm having a net movement of positive outward in this initial phase. Now, there are a couple of other players here that are involved. And so the next channel here is actually a chloride channel. And when the chloride channel opens up, chloride is moving in. Well, that's a negative charge moving in, which means then I'm having a net positive charge on the outside. So therefore, I'm above, because it's making, again, the membrane to be more negative. So that's another factor that is driving this to be in the more negative direction. Again, fighting back the calcium that's moving in terms of what's happening to the action potential during this phase 1. Another player that's involved is the sodium-calcium exchanger. And we've seen this before. This is my NCX. And so this is a simple exchanger, so it's not directly involving ATP or anything. It's just basically two opposite directions. So I'm going to have an exchanger that could go this way. So it could be pulling a calcium in, but it's going to be kicking out 3 sodiums. So when that happens, the net movement, if this is out and this is in, the net movement of charge is out. Of course, I could have it go the other way. In that case, I'm having my calcium leaving, and then I'm having 3 sodiums coming in. In that case, then, my net movement of charge is 1 plus 1 moving in. So this exchanger can go in either direction. So the direction that it goes is really a function of the forces acting on the calcium and the sodium. So in this case here, note I'm in the pretty positive area here. So if I'm in the positive area here, that means I've lost my driver for the sodium to be pushed in and kicking a calcium out. In fact, the greater force is calcium is coming in and pushing a sodium out. Again, why am I pushing a sodium out? Because I'm up here in the positive. I'm getting closer to the Nernst value for sodium. Therefore, I'm losing my driver of pushing sodium into the cell. So this will actually reverse. And so this is exactly what's going on over here. So that means I have yet another net movement of positive going out. So all of these things are coming into play to help with that early repolarization going on. As I move to the plateau phase, in the plateau phase, I'm kind of having, well, it's a plateau. So it's staying there, but I'm having a lot of things going on. So let's draw our eyes down and see I still have my L-type calcium channel. So I'm still having my calcium flow in, again, a +2. But you'll also note now I'm having a significant number of other potassium channels that are opening up, allowing potassium to leave here and here. And these two channels there are going to be my delayed rectifying potassium channels. Also, what's coming into play here is I'm having some potassium that is leaving here. And this is my calcium-dependent potassium channel. And again, if you have to go back and review my lectures on the various types of potassium channels, please do so, because we talked about this before. Calcium-dependent potassium channel. So calcium is coming in and then allowing that channel to open up. So yet another availability of potassium to leave the cell. So as long as this is plateauing here, what that means is that the net change of charge during this phase 2 is 0. So for every positive charge coming into the cell, calcium, I'm having an equal positive charge leaving the cell, potassium. So it's a net 0 gain here. So it just hangs up there. But then also see what's happening, which is during the plateau phase, now my L-type calcium channels are closing. So as they close, now I am leaving, or I'm losing my ability for positive to flow in, and guess what is still happening after these channels begin to close, these L-types? I'm still having potassium leaving, potassium leaving, potassium leaving, potassium leaving. So therefore, now the net movement of charge out of the cell is potassium, and so now I'm bringing this thing down, phase 3, final repolarization. Another curious, interesting thing is we've had now a lot of calcium flow into the cell during the plateau phase. Note what's happening to my sodium-calcium exchanger. Now what's going on is actually reversing field. So now what I have is this scenario. Why? Because it's becoming more negative, which is giving a greater force of the sodium to be driven into the cell, which gives me more energy to start kicking calcium back out. This is pretty handy in the sense of if I have all of that calcium coming in, I really need help now getting that calcium back out for the next loop. So this is one of the mechanisms that's going to help remove the calcium out of the cell as the action potential finishes its phase. Now there's other ways. There's a calcium ATPase pump that also gets in on the act, but this is one of the ways you're literally pushing calcium back out, and you're using sodium to get that energy going. One of the things that's interesting is the last big push in terms of bringing us down to a phase 4 resting membrane potential is going to be my inward rectifying potassium channels. And it's busy over here, so I'm going to write it over here. Inward rectifying potassium channels. Now you'll recall from an earlier lecture when we say it's inward rectifying, all that means is that theoretically it's easier for potassium to flow into the cell than it is out of the cell. If you have an outward rectifying channel, that means it's easier for the potassium to flow out of the cell than in the cell. But calling it an inward rectifying potassium channel doesn't mean potassium is coming into the cell. What determines where potassium is going to go is going to be the electrical concentration forces, Nernst value. So even though we're calling this an inward rectifying potassium channel, potassium is leaving when that channel is open because those are the forces acting on the potassium. So you'll note during the plateau phase, these inward rectifying potassium channels are not quite as open. Maybe a little bit of potassium leaks out. But notice the big kick up here at the end. And the kick up there at the end is meaning a significant amount of potassium now is flowing out. And so the inward rectifying potassium channel is the main channel that really pulls this thing back down to a resting membrane potential, because by the time you get to the end, my delayed rectifying potassium channels have already closed down. And so it is that inward rectifying channel that will give it that last kick, and then it will settle down and go back to baseline yet again. And one other thing, just to make sure I don't leave anything out. Remember, we had a lot of sodium coming in. We got potassium leaving. I've got to reverse that. So now I'm having my ever-present sodium-potassium ATPase pump. So it's going to be kicking out 3 sodiums. And going to be pulling in 2 potassiums, okay, and this is out and this is in. Again, trying to realign the ion distribution. So one other thing I haven't mentioned, because it's not really that important, but this is right here. The IH is really IF, so these are my funny channels. They're not major players. You'll note nothing is happening as far as the funny channels are concerned. Why? Because we are above 0. Remember, that's one of the things that makes a funny channel called funny, is that they don't allow ions to flow through in the positive range. So you do have some funny channel activities with these cardiomyocytes, even the contractile variety, but during the action potential itself, they shut completely down and no sodium is leaking in. So what we see here is just a lovely arrangement of channels that are orchestrating this depolarizing event. Now, a couple other things before we close, and that is, I just need to mention this. What you're seeing here is just kind of a cartoon of a generic depolarization of a cardiomyocyte. If you looked up the depolarization profile of a cardiomyocyte in the atrium, it looks a little different in the sense that it's going to go up and it's going to come down, and then it comes down rather quickly. And so the plateau is not nearly as long. It's just, again, a characteristic of the various types of channels that the cardiomyocytes have in the atrium. The other thing that I want to point out as well is that the action potential profile of a cardiomyocyte in the ventricle will vary depending upon where in the ventricle you are. So it is not the case that the action potential profile in every cardiomyocyte in the ventricle is the same. They all vary. So this is just kind of a simplified cartoon of what a typical one would look like. Okay, last point. is that you'll note that this action potential looks very different than an action potential of skeletal muscle or action potential in a neuron. We've stretched this thing out. The action potential for a neuron or for skeletal muscle will last, maybe 2 milliseconds. Okay, and this is 300 milliseconds here. So 2 milliseconds versus 300 milliseconds, a big difference. Well, I want you to think about this in terms of skeletal muscle. So if I want a more powerful contraction of a skeletal muscle, what's one of the ways you can do that? Well, one of the ways is temporal summation. So if I have a high frequency of action potentials, the higher the frequency, the more the calcium flows in and the stronger the contraction of the skeletal muscle. And think about what skeletal muscles do. Well, skeletal muscles, at least most of them, are designed and function to move a joint. So you got skeletal muscle attached to bone, and then a skeletal muscle attached to another bone across a joint, and as it generates force, it's going to move that bone. So sometimes I need to move that joint in a more forceful fashion, so I'm just going to pop it with high-frequency action potentials. So I need a pretty quick turnaround to do that, and so there are some muscle fibers you can do, many hundreds of action potentials per second to get that effect. Well, think about what the heart does. The heart's not obviously attached to bone, so the heart is a soft tissue pump. And so the cycling of the heart, as we've already talked about, is that it contracts, but then it has to relax, be allowed to fill with blood so it can then contract again. Well, imagine what would happen if an action potential of a cardiomyocyte looked more like an action potential of a skeletal muscle, and then you have some neurosignals where now you're having very rapid sequences of action potentials, one every couple of milliseconds. Well, what that means then is that the cardiac muscle will just contract and stay contracted. Well, if it stays contracted, it can't relax and allow more blood to go through. So if I have a flurry of action potentials in rapid succession, if the action potentials were like skeletal muscle, the heart would just simply contract and you would have tetanus of the heart, and then you die. And it can't function. So in some measure, this long plateau is a bit of a safety mechanism, keeping it from going to, quote, tetanus, in terms of just a contraction that won't let go. So that's one of the lovely things about the profile here of this action potential, is that there's a long period, and we'll talk about this in a later lecture, a long period here where it's in refractory. You remember, you have an absolute and relative refractory period for neurons and skeletal muscle fibers, but it's a very short period of time. Well, in the action potential of a cardiomyocyte that's contractile, I'm going to have a relatively long refractory period, and that's a good thing in terms of keeping the muscle from having another action potential, which of course is going to be impacting the efficacy of the pumping action. Okay, so that's that. Now, one other thing here, I don't need for you to memorize these little guys right here. Okay, you certainly will want to know delayed rectifiers and L-type, T-type, and things like that. But don't get hung up on the little symbols there. I'm not going to put a I, T sub O and then try to ask you what kind of channel that is. I'm not going to do that. Anyway, but I'm hoping this is a really nice visual that kind of shows the sequence of event during an action potential. And as I said earlier, I have tried to have this laid out in terms of verbiage, what I just told you in the past few minutes. All right, so we will close here and pick up next time. Last time we spoke of the contractile cardiomyocytes and how they communicated their action potential from cell to cell. What I want to do here is take a step back and look at the organization of cardiac tissue, and I'm going to compare it to the organization of skeletal tissue because there are important similarities, but there are also important differences as well. So I have a cartoon over here, and that's going to be skeletal muscle. And then over here is going to be cardiac muscle. So what happens? During an action potential in the cardiac muscle, you have a depolarization, goes into the cardiac muscle or cardiac tissue via T-tubules, leading to an opening of dihydropyridine receptors, which are basically voltage-sensitive calcium channels, and these are the L-type variety here. So let's take those words and let's connect them to the cartoon below. So what we have going on here, cardiac, there's a T-tubule here. So what we're having is we're having a depolarization wave that is going to be communicating through the T-tubules, and they are then in turn going to be opening up dihydropyridine receptors or L-type calcium channels. So we had a T-tubule, and we saw a similar motif having to do with skeletal muscle. So here is a T-tubule on the skeletal muscle. T-tubule, how about that T-tubule there? So here he is right there compared to the T-tubule there. So one of the differences you see right off the bat is that the T-tubule on the cardiac muscle is much, much larger than the T-tubules in the skeletal muscle. Now you will recall back in terms of how the skeletal muscle worked was that you had a wave, a depolarization wave going into the T-tubule. Again, it originates on the surface and then goes in, and then you have these, little dihydropyridine receptors are sitting on the T-tubule surface, and they're going to again, as the T-tubule surface depolarizes, it's going to open up those dihydropyridine receptors. And you'll recall here is go different color here maybe. Let's go blue, and we'll do maybe here. So remember you have your lateral sacs here, terminal cisterna, and then of course you got your network of your sarcoplasmic reticulum there. And you'll recall the way it worked in the skeletal muscle. You had a T-tubule here, and then let's say we have let's see, I went the wrong color there, so let me back up on there and try this again. Got that, and we'll go red just to be consistent. So I'm going to have a dihydropyridine receptor there, or an L calcium channel. Okay, and so the wave of depolarization is going to open that channel up, but also what we have in the skeletal muscle, remember we have a lateral sac here, and we'll just go there for my lateral sac or my terminus cisterna, so we'll go TC, and then sitting on that is going to be another type of receptor, and that's going to be my RYR1 receptor, RYR1, and that it is physically connected to the L-type calcium channel on the surface of the T-tubule. And another term for the RYR or ryanodine receptor is going to be foot protein. You'll see that sometimes referred to that way. And so this channel this L-type calcium channel, or the dihydropyridine receptor, opens up, and that because it is physically connected to the RYR1 receptor, the change in shape of the L-type calcium channel will also change the shape of the RYR1, and it will open it up, allowing then calcium to flow out of the lateral sacs. And of course you have your filaments over here allowing the calcium to do what they do regarding the myosin and the actin interaction. So that's how that works. And you might have just a little bit of maybe a calcium flowing in here that might influence the activity of that RYR1 receptor, opening up, allowing calcium in. So that's kind of how we saw that, again, relative to the T-tubule here. So we're going to find out things are a little different when it comes to the cardiac muscle, and I got a prettier diagram that shows you that on the next page. All right, so over here in the cardiac, you have a T-tubule, and the T-tubule also is going to have these L-type calcium channels or the dihydropyridine receptors on them. All right, so you're going to have that. And we'll go red here. All right. And then I'm going to have this sarcoplasmic reticulum. And so the sarcoplasmic reticulum here is going to be this network there. So right off the bat, what you see, there's a difference. You don't have these robust lateral sacs in the cardiac muscle like you do the skeletal muscle. The skeletal muscle has a lot more to the sarcoplasmic reticulum compared to the cardiac muscle. So the cardiac muscle, the sarcoplasmic reticulum is rather exiguous relative to the sarcoplasmic reticulum that you have in the skeletal muscle. Very scanty, very skinny, but again, it's enough to do the job. So that's one thing you're going to want to note. So what you have here, again, just cartooning it out real quickly, is I'm going to have the sarcoplasmic reticulum. I'm just going to say this is this right here. And then I'm going to have, I went green on this one, so we'll go green again. So there, I'm going to have an RYR2. RYR2, a ranodine receptor. So this could be sitting there. Now, one of the differences is for the cardiac muscle, the dihydropyridine receptor is not physically connected to the ranodine receptor. It's very close, but it's not connected. And so again, in this situation here, you'll have a depolarizing wave. It's going to allow calcium to flow in, and the calcium may interact a little bit, or will interact with that RYR1 receptor, and as that calcium flows in there, it's going to open, then allowing calcium then to flow out, and of course you have your actin and myosin over here to do what they do. So that's kind of a simple cartoon of how they're a little different. Again, a much more detailed cartoon on the next page for this. So you have that. So again, you both have T-tubules. They both have sarcoplasmic reticulum, except the sarcoplasmic reticulum is much more well developed in the skeletal muscle fiber compared to a cardiac muscle cell. Another thing you'll note, they're both striated, so you have your I bands, A bands, etc. The arrangement or placement, though, is different. So you'll recall on the T-tubule that you have, it's going to be in line with the AI boundary. Okay, so there's the AI right there, the AI interface there, and it is perfectly lined up with the T-tubule. Here's another AI band, and again, T-tubule. Well, if you look over here in the cardiac, the AI is actually right there. So it is not lined up with the T-tubule. So the T-tubule is actually in the cardiac muscle lined up with the Z-disc. Whereas the Z-disc over here is not lined up with the T-tubule. So yet another distinction in terms of how they're just a little bit different. Okay, and these are common questions you'll get on exams and such. So again, you want to be familiar with basically how things are laid out. Okay, so going back here into the verbiage. Again, contrasting, voltage-gated dihydropyridine receptors, T-tubules do not mechanically, got all that already said. And just kind of going down through here, I've already said all that as well. Let's see, the T-tubule is about 5 times as large as the T-tubules in the skeletal muscle. So it gives you a number there to pay attention to. Again, the Z-discs, I've already talked about that. AI junction, I've already talked about that. And we'll see on the next page, calcium is removed from the cytosol, put back in the extracellular fluid by a NCX exchanger. Again, more on that later. And a calcium ATPase pump. Again, we'll see that on the next page as well. The other thing that I want to point out that's not in the diagram, but is still very useful to know, is with the T-tubules in the skeletal muscle, they're all kind of just in this orientation here. The T-tubules in the cardiac muscles, it looks like they're in this orientation here, but they will actually come in and then turn and go longitudinally. So they'll come in and they'll run this way. I don't know how well you can see that. Maybe I'll go with the red. The T-tubule will come in, and then they'll run longitudinally here, and that it makes it a little more efficient in terms of the axial potential wave going down the T-tubule and exposing itself to more or a greater part of the skeletal muscle tissue, the cardiac muscle tissue itself. So another difference, again, is the T-tubules both run latitudinally and longitudinally in the cardiac muscle, whereas the skeletal muscle is just kind of more lateral. So again, another difference there. Okay, so let's go into and look at the cartoon diagram of a cardiac muscle and just see kind of how things are working. Again, oversimplified diagram, but it's enough for us to have the general idea of how things are working. So we're going to say here that this is going to be the T-tubule. Okay, so we'll label it as such, T-tubule. Okay, so the axial potential then is going to be, going down in that direction there. And so it is going to be then opening up a L-type calcium channel. That's my dihydropyridine receptor. Right there, again, L calcium channel. It's going to open up, allowing calcium to flow in. And the main job of the calcium flowing in is to make contact or interact with the RYR2 receptor, my ryanodine receptor type 2. Again, skeletal's type 1, cardiac is type 2. So this calcium here is actually acting as a trigger for that RYR2, and then it will open, and the vast majority of the calcium that is going to interact with the filaments down here is actually going to come from the sarcoplasmic reticulum. Some could still come from the outside. Okay, so it does get into the act as well, but most of it comes from the sarcoplasmic reticulum. So chain of events, you have your axial potential going down T-tubule, opening up the hydropyridine receptor, lets a little calcium in. Calcium then is going to trigger the RYR2. It will open, calcium flows out. And now we have sources for calcium to be in the vicinity of the filament so that the actin and the myosin then can interact. So you have that. So let's see what we have here. Make sure I haven't left anything out. You got that. Okay, got that. And L channels, got that. Another term for the calcium as it interacts with the RYR2, sometimes you'll see that called sparking. So that little bit of calcium that comes in will spark the RYR2 to open up, allowing more calcium to flow out. What's interesting in cardiac tissue, and the same thing really is true for skeletal as well in terms of the RYR1, is that you can have spontaneous sparking. And you don't want that. It would just open up. And when you have that in cardiac muscle, that could be a problem as far as arrhythmias is concerned, because that's not what you want. Another thing that can go on is that RYR2, if it spontaneously sparks, it can also lead to nearby RYR2s to spark as well. So you start a chain reaction, you get the chain reaction going, and all of a sudden you have an arrhythmia that you don't want. These RYR2 receptors can be regulated by second messenger systems and mechanisms such, calmodulin kinase, which can phosphorylate the RYR2 receptor. Again, I'll make this point over and over again, that all of these major units, functional units, whether it's a receptor or a pump, is subject to regulation by various cellular processes, whether it be by G proteins or phosphorylation or dephosphorylation, etc. So all of these can be controlled and modulated. When the RYR2 receptor is phosphorylated to an increasing degree, that actually can make that channel be more sensitive and allow more calcium in. So an example, RYR2 receptors are responsive to caffeine, norepinephrine, epinephrine, again, probably involving some phosphorylation process where it makes it easier to open up and then obviously affects the functioning of the heart itself. So you have this flow of calcium coming in and doing its thing. Then the question becomes, how do you reset the whole system? Because you can't just always have calcium flowing out. You have to have a way of resetting the clock, so to speak. So multiple things that are going on here. One of them is we have a Circa pump, and this is Circa type 2. Okay, smooth endoplasmic reticulum, calcium. So you see where the Circa is coming from, type 2 in this case here. And it is an ATPase pump. And its job is to take that calcium that was flooding into the intermediate, to the microfilaments here, actin, myosin, and return it back to the sarcoplasmic reticulum. Again, that makes sense. I mean, you got to be able to pump that in there. It's going to take energy to do it for, again, the next cycle. So you have that. Now, you also need to be clearing out the calcium from the inside and pushing it back out into the extracellular fluid. And so one of the things that will do this for you is going to be a calcium ATPase pump. I just got through telling you that the Circa 2 is a calcium ATPase pump. They're not the same pump. Okay, you got many, many different forms of calcium ATPase pumps, and what I'm telling you is that this ATPase pump is not identical to the Circa 2, although they're both calcium ATPase pumps. So here's another way that you can get calcium out of the cytosol or the cardiomyocyte back into the extracellular fluid. Another pump that we've already talked about earlier was the NCX pump. That's an exchange pump. Again, it's going to pull in this case, pull in 3 sodiums to get one calcium back out. Again, the theme is how do you clear the calcium out from the cytosol? And of course, it is using the concentration gradient of the sodium to supply the energy to push that calcium against its concentration gradient and its electrical gradient. Of course, we have to manage the sodium and the potassium, and what's not in here is all the potassium channels. Again, that makes a diagram probably overly busy, but you can understand there are a lot of potassium channels coming in here as well, as we saw on the prior page, but that's just kind of left out of the diagram here, and that's okay. You understand that they're there. But we still have to have a way of managing the potassium, managing the calcium. Of course, we have our standard sodium, potassium ATPase pump that is helping that as well. Okay, so that's kind of a nice scheme diagram, oversimplified for sure, but just gives you a general sense of the movement of the ions and how you regulate those and how you get the calcium into the sliding filaments to get them to do what they do. And then how do you reset, return the ions where they need to be so that you can go through then the next cycle. So again, this is what's happening in terms of a cardiomyocyte. Now again, don't lose sight of you have that cardiomyocyte, but then you have to communicate that action potential to the next one, and that's where we're back into the various types of ways of shifting electrolytes from one cardiomyocyte to another cardiomyocyte, and we talked about that last time, so I'll not rehash that. Okay, so last point on this page that I want to mention is, again, this is kind of a clinical point, it's kind of cool. Catecholaminergic polymorphic ventricular tachycardia. That's a mouthful. Well, tachycardia, abnormal rate of a beating of the heart, so it's racing, it's beating very quickly. Ventricular, telling you where it is happening, because you could have tachycardia of the atria, a tachycardia of the ventricle. So in this case, it's going to be the ventricle itself. Polymorphic, in other words, the wave shapes are very different. And we'll talk more about that later. In a catecholaminergic, again, catecholamines, what are we talking about here? Talking about epinephrine, norepinephrine, theoretically dopamine, etc. So you're putting all these together, just looking at the name, you can get a sense that what I'm having here is I'm having a type of tachycardia of the ventricle, and it is being induced by a catecholamine, epinephrine, and norepinephrine. So what we have here, this is actually a genetic defect. It's an RYR2 genetic defect. This is autosomal dominant. About 1 in 10,000 will have it. And this comprises about 15% of sudden unexplained cardiac deaths are caused by this. Typically, no symptoms. You don't know you have the genetic defect until most of the time it kills you, which is very sad. But what happens is during exercise, as you know, your norepinephrine and epinephrine can increase for a variety of reasons. You're wanting to, again, speed things up because you're exercising, etc., so that is not surprising at all. But if you have this defect, it's overly sensitive to norepinephrine and epinephrine, and it can cause an abnormal amount of calcium sparking. Okay, going back to the RYR2, again, there's something wrong with it. So now it's oversensitive to presence of calcium, particularly if you're having a catecholamine, norepinephrine or epinephrine influencing the RYR2. And we're going to see later that when the heart sees a sympathetic stimulation, again, epinephrine, norepinephrine, there are cellular changes within the cardiomyocytes, and so you're going to have changes in the RYR2 receptor. You're going to have changes in many other things as well. But what I'm saying is that with this genetic defect, you can have a change that in response to exercise, which is going to come through epinephrine, norepinephrine. Something goes sideways. These things start sparking uncontrollably, and now you're going into possibly ventricular fibrillation. So the tachycardia means beating very fast. And you can survive tachycardia, but many times, as we'll find out later, tachycardia can lead to fibrillation, where you have a complete discoordination of the individual cardiomyocytes contracting. So, and if they're not coordinated, then it can't generate pressure in the ventricle. Therefore, you're not pumping blood. If you're not pumping blood, blood pressure goes down, and then, of course, you die. So, pretty interesting, pretty serious stuff. Sometimes the symptoms are there, okay? A lot of times they're not. The first symptom is death, but sometimes, if you get lucky, you'll have some symptoms as you're aware of this. When they are present, again, tachycardia, lightheadedness. Now, why would you have lightheadedness? You'd have lightheadedness because if you have a certain degree of tachycardia, that drops down the efficiency of the heart pump, the pumping action of the heart anyway, because if you're beating too fast, the heart is not able to relax long enough to get blood back into the ventricle for the next push. And so you can certainly reach a point where the ventricle is contracting so fast, so quickly, that it doesn't have time to refill. Then that then leads to a compromise in cardiac output being how much blood goes from the heart to the rest of the body. And then if you're compromising cardiac output, you're compromising blood pressure, you get lightheaded. Dizziness or syncope, same sort of thing. Well, they're not the same thing, but similar. Also, this particular pathology can cause after depolarizations. We'll talk about that later, but just quickly here, recall last time we have a action potential of a cardiomyocyte, something like that. Okay, normally it would go like that, right? Well, an after polarization is where, let's see if I can get up. Okay, well, I can still do this. It's going to go down, and it's going to go down like that. Okay, but once it gets beyond its refractory period, now all of a sudden now you have a series of action potentials before it reaches baseline. Again, we'll elaborate on that later, but that's not a good sign when you have this type of after depolarizations. This particular genetic defect, if you have symptoms, it's going to be typically going to be approaching or going to be appearing a child between 6, 7, 8, 9 years old, somewhere along in there. And again, that's when these problems can arise. Okay, so that's kind of a whirlwind tour of what's going on as far as movement of calcium and then managing all the ions for a cardiac muscle. All right, so we will pick back up next time. My next topic that I want us to consider is what happens with the heart function relative to input from the autonomic system. You know we have two parts of the autonomic system, parasympathetic and sympathetic. You also know that the sympathetic is going to be increasing the heart rate. It will increase the force of contraction of the heart, leading to overall increase in cardiac output. You also know that the parasympathetic input to the heart, which is mediated by one of the branches of the vagus nerve, the 10th cranial nerve, will have sort of opposite effects in the sense that it is going to cause the heart rate to slow down. It doesn't have as much of an effect in terms of the power of contraction that the sympathetic does. So the sympathetic and parasympathetic are not exactly mirror images of each other. Certainly one will increase the heart rate, the other will decrease the heart rate, but the sympathetics will have a significant effect on the force of contraction, where the parasympathetics not particularly. So one of the other points that I want you to understand is that, as we've said earlier, the generation of the beating of the heart itself is completely autonomous. It doesn't need any neurological input to beat. So the beating originates within the heart. And of course, the main place is going to be the SA node. And we've already talked about all that business. But one of the things you're going to want to remember or to consider is that you always have autonomic input to the heart. So it's not like you have no sympathetic input to the heart until you start exercising or until you start becoming fearful or something that would affect a sympathetic event. You have a baseline sympathetic input to the heart. And as you already know, the neurotransmitter associated with the sympathetic is going to be norepinephrine, and of course the adrenal glands, if they get involved, it'll be epinephrine. So you always have a baseline of sympathetic signal to the heart. So even if you're sitting calmly in your chair, you still have a baseline level of that. You always have input from the vagus nerve. You always have input of sympathetic to the heart. And it's trying to slow the heart down. Your sympathetic's trying to speed the heart up. So you can view them, one as an accelerator and the other as a brake pedal. So I have both of those coming into the heart at the same time, a basal level, regardless of what you happen to be doing at the moment, and they're pushing against each other. So I am gently pushing the accelerator and the brake at the same time. Now, in medical speak, we say that we have an autonomic tone. You have a sympathetic tone to the heart. You have a parasympathetic tone to the heart. So they're pushing against each other. So if you can go with the analogy of I'm gently pushing on the brake, and I'm also gently pushing on the accelerator, then what if I were to pull off the brake, not change the accelerator, I still have a positive effect in terms of increase in heart rate, yes? And I didn't do anything to the sympathetic tone. I just backed off the parasympathetic. Or I could not mess with the brake and then alter the accelerator. I don't know if I said that correctly or not, what I just said. So let me go back and say that again. The accelerator is going to be your sympathetic, your brake is going to be your parasympathetic. So again, if I hold one steady but back off the other, I'm going to have the desired effect of what you would expect. So all that to say, if you alter one or the other, you're going to be altering the activity of the heart, but they're always there. So I guess a more specific example would be again, your heart is beating. You have your sympathetic tone coming in. You have your parasympathetic tone coming in. And then for whatever reason, you have an increase in your vagal tone, an increase in your parasympathetic tone. You haven't altered the sympathetics, but you have an increase in the parasympathetics from the vagus, and now you're having neurotransmitters being released, and the neurotransmitters, acetylcholine, which is going to be your parasympathetics, is causing the heart to slow down. Now, the sympathetics haven't changed, but if you have an increase, a significant increase in your vagal tone, then you're going to get lightheaded and possibly pass out. And that is what one of the things we call that is vasovagal syncope. So increase in vagus tone slows the heart down, decrease in cardiac output, drop in pressure, and now you're lightheaded and possibly will pass out. So again, what I did there is that I tapped on the brakes, but I didn't move the accelerator. And so slowing the heart down. So you have this interplay, okay? All right, so let's kind of get down into what's going on with all of that. So we're going to take sympathetic as being our launching point. So this should be a familiar diagram. So this is going to be kind of a cartoon illustrating the typical undulating pattern for these pacemaking cells, and we're just going to assume this is for, say, SA node. Okay. And so here's your undulating pattern, and here are the various channels at play. And this particular diagram here, as we did in an earlier diagram, he has it labeled IH, and that really is IF, as in funny channels. So I'm having my funny channels here, and of course you know that the sodium is dripping in with the funny channels. Okay, ever raising the membrane potential. This is, by the way, we're going to consider this to be baseline here. That would be normal. So we have that going on. And then, of course, we hit the threshold for the T-channel calcium. And then that's going to bring also, quickly following that will be my L calcium. And so I'm going to have a depolarization. Note it doesn't get very high. And then those close, and then I'm going to have my potassium channels are going to open, and I'm not going to rehash all the potassium channels. You can go back to earlier lecture for that. And then the potassium is going to be flowing out in excess of the calcium flowing in because they're closing, and then I'm down back towards repolarization, and then get to do it all over again when the potassium channels close down. Then I'm back to my set point again. So you have that undulation pattern over and over. Well, when you have a sympathetic event, and that's going to involve epinephrine, norepinephrine, they're going to be binding to the receptors, and the main receptor is going to be a beta-1 adrenergic receptor. That's going to be the main receptor as far as heart tissue is concerned. You do have some beta-2s there, but they're kind of minor role. So a big player is beta-1. So you're going to have your norepinephrine and your epinephrine binding to beta-1 adrenergic receptors. It's going to kick up the cyclic AMP, and then again, cell biology happens at this point. As you know, the cyclic AMP can lead to a variety of cellular changes. Things may get phosphorylated, dephosphorylated, etc. So what's going to happen when you have an elevated cyclic AMP? Multiple things happen because you have many of the regulating points are going to be altered because of cell biology. So one of the things that's going to happen is going to be affecting the funny channels. And so now the funny channels are going to be a little more generous in terms of allowing sodium in. And so what you're going to get then is just something happening a bit quicker. And so now here is going to be my sympathetic side of things, where through cell biology, my funny channels are now more liberal in terms of allowing more sodium in per unit time. So I'm going to have a quicker ascending phase to get to that threshold for the T calciums. And of course, they're going to open up more rapidly, okay, because again of the effect on the funny channels here. So you have that going on. And then also you're going to have an opening, or the voltage-sensitive sodium channel, voltage-sensitive potassium channels are also going to be influenced as well, again, by cell biology. So now they're going to open up more quickly and allow more generous amounts of potassium to leak out of the cell. And so the end result of all this is that things happen more rapidly, you see. This is oversimplification because probably the calcium channels are also affected by cellular processes in response to the norepinephrine and the epinephrine. So that's going to happen. Of course, the theme here is that everything happens more rapidly. Another thing that happens as well is that these potassium channels open up, allowing more efficient potassiums to efflux, and then they're going to close, and you'll note that they close, they don't get quite back down to the negative level that they were normally. So what does that mean? What that means then is it's a shorter amount of time then to get to the threshold of the calcium T channel. So you have a little bit of a shift in terms of where you're bottoming out as well. So all of these things point to the same direction of basically having a quicker flow of the sodium coming in, the calcium coming in, and then the potassium leaving. So it ramps everything up. Many other processes also are affected by the binding of norepinephrine, epinephrine to these beta-1s. You're going to get a kick up on the activity of your sodium-calcium exchange pump, so it's going to be spinning faster. Again, it makes sense because I'm getting more calcium in, I'm getting more sodium in and such, so it's got to be doing its thing more quickly. In fact, all the pumps involved, typically because of a various cell biology downstream effect from that initial binding of norepinephrine and epinephrine to the beta-1s, is going to be causing everything to happen very quickly. So what you get then is this pacing, a rapid pacing or a quicker pacing of what's going on with the SA node. And then, of course, if it's firing more rapidly, then everything else is happening more rapidly as well. So that's kind of the pacing of things. As far as the force, the stronger contraction, the sympathetic system will cause, again, a more forceful contraction of the heart. So we would call this a positive inotropy or inotropic effect. So it'll be positive inotropy. And so inotropy is a medical term for force of contraction. So if I have a positive inotropic effect, that means I'm having a more forceful contraction. If I have a negative inotropic effect, that means I'm having a weakening of the contraction or less force of the contraction. So we just saw last time how important the calcium is in terms of getting in there and causing the actin and the myosin to interact and such. So what's going on with that? Again, norepinephrine, epinephrine binding to the beta-1s. Again, beta-2 minor role. Increases force of contraction. Multiple mechanisms at play here. One of the mechanisms is you're going to have more calcium flowing in. So we're going to have an increased opening of these L-type calcium channels. So more calcium flowing in means then I'm going to have a more forceful contraction as you think about the calcium interacting with the myosin and the acting and the ratcheting business. This, through a series of cellular biological processes, you're going to have increased RYR2 receptor as well. So things are going to happen more rapidly there. So again, generating more calcium coming into the cell. You're going to have a ramp up of that SERCA2 pump. It's going to be spinning more rapidly. You remember that's an ATPase pump, SERCA type 2. So I'm going to have that going on. So the overall feel here is I'm going to be delivering more calcium into the cell, and that's going to accelerate the force of contraction, of course. Now, the increase of force of contraction is not, the main one is that you have an increase in calcium, for sure, but it's not exclusively that way as well. There are other cellular processes that can affect the actin and the myosin. Such that it makes it work more efficiently. You can actually have cellular processes that will cause the affinity for the myosin for the calcium to increase. So these cellular processes can actually influence myosin. And so that would be yet another way of having a positive inotropic effect. Again, that's just an example. So my point is that the main mechanism for an increased force of contraction is going to be more calcium, but there are other cellular processes, such again, that can alter the nature of the actin and the myosin that could cause a more forceful contraction. And then, of course, if we're doing that, we also have to accelerate everything else, because if we're dumping more calcium in, we have to be better at getting the calcium out. So all these various pumps are also being affected and acting more efficiently in response to that as well. Okay, so that's it for the sympathetics. So we'll take a look at the parasympathetics in the next block. So last time we talked about the sympathetic influence on the heart. Then again, remind you that we have a baseline sympathetic tone to the heart. We have a baseline parasympathetic tone to the heart. And they're pushing against each other. Again, the parasympathetic is kind of like our brake pedal, and our sympathetic is our accelerator, and we're mashing both of them at the same time. And so if you alter one or the other, you're going to get a physiological change in how the heart is operating. So let's turn our attention then to the parasympathetic side of things. And as we've said, it is the vagus nerve that is going to be supplying that. And so when the parasympathetic tone is increased, or what it's wanting the heart to do is to slow down its heart rate, and we call that bradycardia. Remember, increasing the heart rate we could call tachycardia. And the way it will do this is going to be releasing acetylcholine onto the SA node, the AV node. And one impression I hope I didn't leave you last time with is that the input of the autonomics, whether it's parasympathetic or sympathetic, isn't just on a particular node. Both of them are going to be influencing SA node, AV node, bundle of His, bundle branches, etc. Same for both. So your parasympathetic and sympathetic inputs is going to many, many places in the heart, releasing either the epinephrine or norepinephrine or the acetylcholine. So as you know, the acetylcholine is going to be binding in the heart to the M2 receptor. Again, that's a muscarinic receptor. So when the acetylcholine binds to the M2 receptor, all kinds of cellular processes are influenced. So one of the things that happens when you have the acetylcholine binding to an M2 receptor through a series of cellular processes is going to end up inhibiting the funny channels, slowing the influx of sodium into the SA node in this case, which then is going to be altering the timing of things. So you will recall that you have different phases of the undulation. This again would be an SA node here, noting that, and of course this is normal. So you have your 0 phase, you have your 3 phase, and then you have your 4 phase. So it is phase number 4 where you have your funny channels opening up, allowing sodium in, and then that is going to cause this drift up towards the threshold. So at that point then you have your T calcium channels opening up, and then following that your L calcium channels opening up. Then they're going to close, and then you're going to have your potassium channels opening up, allowing the membrane to repolarize. They'll close down, and then we're cycling all over again. So point being, though, is that if the effect of the acetylcholine binding to the M2 receptor is to cause those funny channels to be more stingy in terms of how much sodium is coming in, that's going to slow the process up. And so here is a diagram here showing the parasympathetics. So I'm going to have a slower depolarization here simply because it's taking a longer time for those funny channels to allow sodium in because they're being influenced by cellular processes that resulted from the acetylcholine binding to the M2 receptor. Of course, we saw quite the opposite when we looked at the sympathetics, because when the norepinephrine or epinephrine is binding to the beta-1 receptors, that's also changing the funny channels, but in that case, they're allowing the funny channels to allow more than normal sodium coming in, which accelerates the process. So quite the opposite effect in terms of parasympathetic and sympathetic. One of the other things that this process will do as well is that it is going to be inhibiting the T channels and L channels calcium. That's going to slow that amount coming in, so I'm going to have less calcium coming into these pacemaker type of cells, and so that's going to have its own effect as well. And again, slowing everything down. And then another thing that's going to happen is that the acetylcholine M2 complex is going to cause an increase in potassium efflux, again through various cellular mechanisms. So what you have going on here then is that I have an increase in potassium efflux, and what's going to happen is they're going to stay open longer, these potassium channels, because they're being altered by the acetylcholine. And so it will actually allow the membrane potential to go lower than it would be normally. So in this case here, we've got it going or dipping, the trough is dipping to a minus 60 millivolts. Well, because these potassium channels are opening up longer period of time, it's going to actually cause the membrane to get closer to the potassium Nernst value. And so if it is then hyperpolarized, so that again, it takes a longer time to get to that depolarizing event, opening up those T calcium channels and L calcium channels. So combination of, again, altering the slope of the four-phase, the hyperpolarization, the slowing of calcium coming in, et cetera, it all works together to where you have a slower pulse rate or slower pacemaking rate coming from the SA node and the AV node and all the other nodes, in fact. So that's kind of the long and the short of the parasympathetic influence on the pacing of the heart. Again, all these cellular processes altering these channels and such, altering the profile here. And as I said before, the parasympathetic event, for whatever reason, doesn't have much influence on the force of contraction. So there's not much of a negative inotropic effect from the parasympathetics. Now you have a big positive inotropic effect from the sympathetics, but not the parasympathetics. So anyway, that's kind of what's going on here in terms of its influence. A side point before I go on to my next topic, and that is, again, you have this tone of parasympathetic, sympathetic going to the heart. It actually will undulate in response to your breathing pattern. So if you, during your inhale phase of respiration, there will actually be a slight increase in heart rate. And then when you exhale, there'll actually be a slight decrease in your heart rate. And you can actually see this on a patient if you ask them, okay, breathe in slowly and deeply, and then breathe out slowly. And you can actually see the variation of the heart rates during inhaling and exhaling, and that has to do, again, with modulating the parasympathetic and sympathetic tone going into the heart. So that's kind of cool. Okay, last little thing I want to talk about is I'm going to talk about a few cardiac drugs, and so right now what I want to talk about are cardioglycosides. So two common cardioglycosides is going to be digoxin and digitoxin. Both of these are considered digitalis, and you may have heard of that term. And so digoxin and digitoxin are from the foxglove herb, and they're going to increase force of contraction of the heart, actually going to allow an increase in cardiac output. In the old days, it was known that if you chewed on these foxglove herbs. They can actually, again, affect heart rate. And so if you were involved in some type of an athletic event or something like that, you need a little extra boost, you chew on the foxglove herbs and it would give you that little added lift. That's not how we use it today, though, but that's how it was used long ago. The digitoxin is not used in the USA. There are some issues in terms of some bad effects when you give patients those drugs. And so if you're in the US, what you're going to be using is the digoxin. The digoxin can be used for some types of heart failure. Again, so if you have them, typically as an elderly person, they're towards the end of their life and their heart is weakening. And so now, because of the state of their heart, they're not able to generate as much force during contraction. So they need a little extra help. And so one of the things that you can give them is digoxin, and that'll have a positive inotropic effect, helping the heart to beat more forcefully. And if we're talking about how would a heart beat more forcefully, then you know you're talking about increasing the level of calcium. Another drug that we can talk about is Wabane. And Wabane is also considered a cardiac glycoside and has the same mechanism as the digoxin and the digitoxin. I'm about to bring these two together in a second. But the Wabane comes from plants in East Africa, and it was actually used for poison on the tips of spears, and it got its name from the Somali word wabo, which literally means arrow poison. So when you read about Wabane, think arrow poison. This is not used in the U.S. for medical purposes. Again, there's some side effects to it that is not particularly pleasant, and so we would not want to use it on a patient, but it's used all the time in science labs and experiments and stuff, so it's kind of cool. Okay, both of these drugs, the cardioglycosides, which would be digoxin or digitoxin and Wabane, these are going to inhibit my sodium-potassium ATPase pump. So let's go ahead and draw this thing out, put this thing together. Out, in, and I'm going to have a sodium-potassium ATPase pump, so it's going to boot out some sodium, and it's going to pull in some potassium. So we have that there, and it's going to be a 3-to-2 there. So both of these inhibit. So there. And there is going to inhibit that. Okay. I made a similar point regarding other proteins associated with cell function. I'll make the same point here. There's not one type of sodium-potassium ATPase pumps. There are many, many varieties. So you'll have a drug that will have a greater affinity on some isoforms of sodium-potassium ATPase pumps and less on others, okay? So these drugs seem to have a pretty good affinity and effect for the sodium-potassium ATPase pumps that are associated with cardiomyocytes. So the question then becomes, how is it that inhibiting a sodium-potassium ATPase pump is going to cause a more forceful contraction of the heart? All right, so just assume more forceful contraction of the heart means more calcium in the heart. So another way of asking that question is, how is inhibiting the sodium-potassium ATPase pump going to get me more calcium in the heart? Well, let's bring back something we've talked about earlier, and that is this guy right here. So this is my good old friend NCX, my exchanger pump. And so its job is to take calcium that's in the cytosol of the cardiomyocyte and put it back into the extracellular fluid. Now I'm pushing calcium up a pretty intense energy grade. So I've got a lot of potassium outside the cell, and I'm also pushing against the electrical forces, so it takes a lot of energy to push a calcium or take a calcium from the cytosol and put it back into the extracellular fluid. So where does that energy come from? It comes because I have a lot of sodium on the outside and a little bit of sodium on the inside. So I'm using that energy of the sodium, in a sense, flowing downhill to push the calcium uphill. Again, there's no free lunch here, so think Gibbs free energy, but it works out. It's because you got to get the calcium out of the cardiac cell if you want for it to relax, take in more blood, and then go another cycle. So putting this together, if I am inhibiting my sodium-potassium ATPase pumps, that means over time I'm going to be compromising that sodium gradient. And if I'm compromising the sodium gradient, that means I'm losing my energy to pull the calcium out of the cytosol, putting it back in the extracellular fluid. So at the end of the day, if I'm inhibiting this pump to enough degree, I'm going to start making it harder to pull the calcium out of the cardiomyocyte, which results in a higher calcium level, and the higher calcium level then in turn results in a more forceful contraction. So that's pretty slick in terms of how all this works, but that's kind of the basics here. We're going to talk more about some of these things in a later lecture, but that's kind of fundamentally how these things are going to work, both the Wabane and the digoxin and the digoxin, et cetera. So you have the interaction of the sodium-potassium ATPase pumps being inhibited, which causes then compromise function of my NCX. Okay, so we'll end this here, and we'll pick back up next time. We'll talk about a few other cardiac drugs that are common in cardiology. I want to consider a common cardiovascular problem called angina pectoris. You can also pronounce that as angina pectoris. The pectoris comes from the word for chest. Angina is Latin for the word for strangle, so that angina pectoris literally means strangling of the chest. And what it involves as far as symptoms are concerned is the patient is going to be having or experience a pressure or tightness of the chest. It may involve chest pain itself. The pain may not only be associated with the chest, but it may be associated with neck or shoulder or arm or upper abdomen. When that happens, that is called referred pain. And medically referred pain has to do with you have some type of offending organ in your body trunk that's irritated, but you feel the pain in response to that irritated organ somewhere else. There is a neurological basis for that, but in medical speak, that is just simply called referred pain. In addition to discomfort of the chest or chest pain or referred pain, the patient may have dyspnea or shortness of breath. They may experience sweating. They may experience nausea. None of these are necessarily present, but it wouldn't be uncommon for them to be present. The bottom line is when the patient is having angina pectoris, what is going on is that you're having a metabolic demand of the heart that is exceeding its own blood supply. As you know from every organ system you've looked at, you have a metabolism going on in the organ system, and then you have the blood supply that is going to be supplying its oxygen and its glucose. But if the metabolism of the organ is exceeding the oxygen and glucose supply, then you're going to have a problem. And that's essentially what we have here with angina pectoris, is the heart is working beyond its own blood supply. And the question is, what's going on with that? Well, the heart has to have its own blood supply through what is called coronary vessels. So as you know, when oxygenated blood is coming from the lung and going into the left atrium and then drops into the left ventricle, and then the left ventricle is contracted and is pumped into the arch of the aorta, that oxygenated blood in the lumen of the atria and the ventricles is not going to be of much help or any help in terms of delivering oxygen and glucose to that tissue itself. That blood in the lumen of the chambers of the heart are just passing through. So as the left ventricle contracts, pushes the bolus of blood into the aorta, at the base of the aorta, just above the aortic arch, the aortic valve, you have a right and left coronary artery that loops back around and will feed the heart its own blood supply. So you have a right coronary artery, left coronary artery, and they're going to branch off into other named arteries, and we're going to learn some of those names in a later lecture. But every time the left ventricle contracts, it literally is pushing blood into the coronary artery so that it can feed itself. So the problem becomes if you have something that is compromising that coronary blood flow, restricting it, then you're going to be creating myocardial ischemia, again, a shortening of the blood supply to the tissue itself. Now, why would that happen? Lots of reasons for that. One could be that the patient is having some plaque build up in there. So as you know from other studies, the plaque builds up beneath the endothelium of the blood vessel, and the plaque buildup is going to be tied to cholesterol and other biochemical processes. And as that plaque builds up, pushes into the lumen, reducing the radius, therefore increasing the resistance and making it harder for blood to flow through the coronary arteries. You could also have a rupturing of the plaque, such that the plaque content punch through the endothelial layer, and then when that happens and you have little pieces of plaque breaking off, then that's going to create a blood clot, and so now you have coronary thromboses around, again lodging in the coronary arteries, causing great compromise of blood flow there. Or you could have arterial spasms, those smooth muscles in those coronary arteries just contract for whatever reason, again decreasing the radius, increasing the resistance, leading to compromised blood flow to the heart tissue. So lots of ways of getting there. You have two basic classes of angina. You have stable angina and you have unstable angina. Stable angina is also known commonly as effort angina, and the name is very descriptive because with effort angina or stable angina, the patient, while they're at rest, they're fine. No discomfort, no pain, no anything, everything is good. But when they get up and try to exert themselves, maybe they're climbing the stairs, maybe they're mowing the grass, whatever, then all of a sudden they have that tightness of chest or the pains or shortness of breath or whatever, but it's tied to exertion. So at that time, what they're doing is they're asking the heart to go beyond the blood supply. Typically in stable angina, if you sit back down, calm down, rest, then the pain goes away after a few minutes. Another cause for stable angina, not a cause for stable angina, the cause for stable angina is compromised blood flow, but something that could bring about stable angina would be some type of emotional distress, because if you're dealing with emotional distress, that can be a sympathetic thing, and so you're stressed emotionally, the sympathetic signal goes up, increasing the sympathetic tone to the heart now beats more rapidly, more forcefully, and then again, it's going beyond its metabolism is going beyond the blood supply. So emotional stress could also bring about an attack of stable angina. Unstable angina is a form of acute coronary syndrome, or known in medical speak as ACS. There are different kinds of ACS, okay? There are different types of ACS. And so what I'm saying is that unstable angina is one type of ACS. The symptoms here basically involves that the patient, even at rest, is experiencing discomfort, tightness of chest, or whatever. So it's not really tied to exertion. They can be very calm and still or struggling with this. And I think kind of the standard is you have those attacks or those periods of discomfort have to last more than 10 minutes. And you may be uncomfortable for 10, 15, 20, 30 minutes. Then it goes away, and then it comes back, then it goes away. So that would be kind of a classic unstable angina, but doesn't have much to do with effort because you can be calm, cool, collected and still have that. This is more serious than the stable angina, and many times the unstable angina could be a predictor for a future heart attack. And of course, heart attack is defined as having a myocardial infarction. So this is something pretty serious and needs to be treated. Now, there are a number of ways that you can work with someone that is struggling with angina pectoris. Clopidogrel is going to be one drug that is considered an anticoagulant. You've seen the commercials on TV. They call it Plavix. And again, why would you want that? Well, if somebody has angina pectoris and they're throwing off blood clots, then that may be one of the causes for that. You want to make sure that the patient is not throwing clots off to make this situation worse, and so you'd want to put them on an anticoagulant. Another type of drug would be statins, and I'm pretty sure you're familiar with statins, but statins is going to be basically a cholesterol drug to lower the level of cholesterol. If you lower the level of cholesterol, it really can help in terms of impeding plaque formation. All kinds of statins out there. Another approach would be nitrates. And again, I'm sure you're familiar with this, nitroglycerin. Nitroglycerin, typically you'll put it under your tongue, sublingual, and it's pretty rapid, and it will cause an increase in nitric oxide. And nitric oxide is a pretty potent vasodilator, so it's going to dilate blood vessels. And if it's dilating blood vessels, that means it's going to dilate or vasodilate coronary arteries as well. Again, has side effects. If it's dilating your blood vessels, then you're probably going to be having a blood pressure drop, lightheadedness, etc. But if you're dealing with angina pectoris and you're bringing on, and you have the tightness of chest or the pain, you pop a nitroglycerin pill, and that can dilate those arteries to where now you're getting adequate blood supply to the heart pretty quickly, and it will resolve your discomfort. Another class of drugs would be calcium channel blockers. Calcium channel blockers would also dilate or vasodilate blood vessels, which would include, of course, coronary arteries as well. And so you could put your patient on calcium channel blockers. Another drug of choice would be beta blockers, and the beta blockers are going to be blocking the effect of catecholamines, and in this case, catecholamines meaning epinephrine and norepinephrine. And so if you're on a beta blocker, that means, again, with the norepinephrine or epinephrine influence on the heart, if you're blocking that, then that's going to slow the heart rate and it's going to lower blood pressure. And it is also going to be keeping the sympathetic tone from causing the heart, the heart to beat more forcefully. So I just kind of want to take a step back and kind of dwell on that because I'm about to talk about beta blockers in a minute anyway in more detail. But if you have the problem of your metabolic or metabolism of the heart going beyond its blood supply, particularly in the context of beta blockers, if you put the patient on the beta blocker, again, blocking beta adrenergic receptors, that then is going to keep the sympathetics from overstimulating the heart. Because again, if you exert yourself, increased sympathetic tone causes the heart to beat more rapidly, more forcefully, and we went through all those mechanisms in an earlier lecture. You're literally blocking that. So that's why you have beta blockers and they do what they do. Again, lots of options here. A procedure that you could do for someone who struggles with this is to have angioplasty and put a stent in, particularly if the problem is going to be plaque buildup and you need to open up those coronary vessels. That would be a procedure that's very effective. If you're treating the patient with drug therapy, you could either go monotherapy or combination therapy. Monotherapy, basically, as the name implies, you're just giving them a drug. So you may give them a beta blocker, or you may have them on calcium channel blockers, or you just may be treating them with nitrates. So just pick a drug and see if that helps the patient. Or you could do combination therapy. And that's where you're putting a combination of drugs. And so maybe you'll put them on a beta blocker and maybe calcium channel blockers. Now you have to be careful with that because you can't take, there are some calcium channel blockers that you can give the patient in combination with beta blockers, and there are some calcium channel blockers you can't. So you have to be really careful in terms of how you combo these drugs if you're doing combination therapy. Some people will be on nitrates and calcium channel blockers, and they won't be on the beta blockers. Each of these have their own set of side effects, and so you kind of have to figure out what combination of drugs is going to work best for your patient. Another thing that you have to be attentive to is the patient, most of these patients are older, and so they may have angina pectoris, but they also may have other conditions. And some of these drugs, if you give to treat angina pectoris, may have a less than desirable effect regarding other pathologies that they may be having. So again, you have to look at a patient as a whole to figure out all the things that are going wrong with them and make sure that you're going to be doing something in terms of the angina pectoris that's not going to exacerbate another pathology. Okay, so I want to return now to just adrenergic receptors in general. We've talked about these before. But you have your alpha-1, alpha-2, beta-1, beta-2, beta-3s. There's also a beta-4 out there I'm not going to talk about. But one point that I want to make also, and I made similar points in other lectures about this, say for example, alpha-1s. There's not just one alpha-1. You have subtypes of alpha-1, and you have subtypes of alpha-2. So again, this is more complicated than even what I'm laying out here, but I'm trying to speak in generalities. So by and large, your alpha-1, alpha-2s, if they are working on smooth muscles, when bound, they're going to cause smooth muscles to contract. If you're looking at your beta receptors, and if they are associated with smooth muscle, and they're being bound, then they're going to be causing smooth muscles to relax. So you have a different response on smooth muscles, whether you're talking about alpha receptors or beta receptors. Now again, you can have alpha and beta receptors on other organs, and whatever effect they're going to have is going to be a function of the cell biology of that organ. We've already talked about your beta 1s being associated with cardiomyocytes, and then when the epinephrine or the norepinephrine binds to a beta 1, again, you have your series of events that affect cardiac function. So as far as alpha-1, alpha-2s, most of your receptors on smooth muscle are going to be alpha-1s. I'm not saying that you can't have alpha-2s on smooth muscles. I'm just saying most of the time they're going to be alpha-1s. Alpha-2s very commonly are found on neurons. Am I saying that neurons couldn't have alpha-1s? No. Okay, I'm just saying that alpha-2s tend to be very common in neurons. So I'm not trying to oversimplify to the point of being too specific here. I'm just kind of waving my hands at some general principles. As far as your betas are concerned, most of your beta 1s in your body are going to be associated with cardiac function. And so I've read from different sources. Some people say 75 to 80% of the beta 1 adrenergic receptors in your body are associated with the heart in one way or the other. I'm not saying that you can't have beta 1s in other places. You can. You can have beta 1s on neurons. You can have beta 1s on other organs. I'm just saying that the beta 1s seem to be dominant in heart. If you look at the lungs, and you'll recall this from earlier lectures, the lungs have mostly beta 2 receptors. Okay, and we recall again earlier where if you have epinephrine, norepinephrine, binding to the beta 2s, that's going to cause relaxation of smooth muscles, going to open up airways, allowing breathing to occur. Didn't mention beta 3s. Okay, beta 3, not as much known about them, but a lot of literature about their function in bladder. Okay, in terms of smooth muscles there, there also could work in smooth muscles of small intestines. Fair amount of literature on beta 3s on fat metabolism. And they are found in white and brown adipocytes. Adipocytes. Okay, so that's a little something about the beta 3s. We've talked about this before, but you have varying affinities on this. And so, I'm going to speak in generalities, okay? So your norepinephrine tends to prefer alpha receptors over beta receptors. And again, norepinephrine, again, think about it, that is your main workhorse for your sympathetic system. Your sympathetic system is innervating blood vessels for blood flow control. And what did I just say? Most alpha receptors are alpha 1s. And so that kind of makes sense, I suppose. When you get into the norepinephrine where it prefers alpha 1, alpha 2, they're about the same. It does have a much stronger affinity for beta 1 compared to beta 2s. So the norepinephrine, again, as far as affinity, alpha over beta, it's actually the opposite for epinephrine. Epinephrine, a greater affinity for the betas over the alphas. And again, if you'll may recall, this is why if somebody is in anaphylaxis, again, constriction of airways because of a reaction to something, you're not going to give them norepinephrine. You're going to give them epinephrine because you want that epinephrine working on those beta 2s to open up those airways so that the patient can breathe. Another kind of, just affinity type of thing, your beta 1s, norepinephrine, epinephrine, kind of about the same. Your beta 2s, again, strong preference for epinephrine over norepinephrine. Flip with your alpha 1s, norepinephrine over epinephrine, and alpha 2, epinephrine over norepinephrine. So again, just kind of give you a sense of the various affinities of these receptors relative to norepinephrine or epinephrine. Okay, so let's go a little bit more into beta blockers themselves. And again, some of this is repeat, but I'm just trying to make a point here. So your beta blockers, most of, again, your beta 1s are going to be on cardiomyocytes. These are metabotropic receptors. Again, we've already talked about all the things that it does. We've already talked about what it does if it's on a contractile cardiomyocyte versus a non-contractile cardiomyocyte, such as your pacemaker cells. And I'm not going to rehash this, but the end result is if it's a contractile, you're going to end up with greater calcium. Greater calcium means more forceful contraction. If the beta 1s that are associated with your non-contractile cardiomyocytes, they're going to be quickening the pacemaker, and of course that is going to be increasing the cardiac output by increasing heart rate itself. So your beta 1s, again, going to be receiving your sympathetic tone, and so if I'm having a drug and I'm actually blocking that, then again I'm impeding the sympathetic tone, dialing down, making sure the heart doesn't beat too fast, and making sure it doesn't beat too forcefully relative to blood supply. I haven't mentioned this before, but I think the term is obvious. If you're having epinephrine or norepinephrine causing the heart to increase its rate of contraction, that's called a positive chronotropic effect. It's kind of obvious. Of course, I've already talked about positive inotropic effect and increasing force of contraction. So I might want to toss that word out there for you, positive chronotropic effect. So again, beta 1 receptor blocking, I'm going to block that sympathetic tone, thereby impeding the heart metabolic rate, slowing the heart down. Beta blockers also are going to affect kidney by reducing renin release. And you may recall when we did kidney, we talked about that. So lowering the renin is going to be reducing blood pressure by two mechanisms. One is I'm going to be lowering the extracellular fluid. Why am I lowering the extracellular fluid? Because renin is going to end up causing an increase in angiotensin II. Okay, and so if I'm lowering the renin, I'm lowering angiotensin II, which means then I'm going to be excreting more amount of body fluid, thereby lowering the total extracellular fluid, thereby lowering the blood pressure. Also, angiotensin II is a known vasoconstrictor, so anything that causes me to lower A2 means then I'm also going to be having a lower blood pressure. So again, you're wanting to block all of this. Again, the theme here is just keeping the blood pressure low and making sure that the heart doesn't go beyond its blood supply. Just kind of a side point here, your cardiomyocytes do have some alpha receptors. Okay, they're not that many. Okay, but they are there. Again, I'm not trying to be absolute here. Many of these receptors in many of these areas, but I'm just saying that the dominant one for cardiomyocytes is going to be beta 1s. You can find alpha 1, beta 2 adrenergic receptors on coronary vessels. So your alpha 1 receptors are found on the epicardial coronary vessel. Again, those are the vessels on the outside. And they constrict. Now, I want to say this very minor, because literature will show you or say that with normal sympathetic tone, the response in terms of vasoconstriction is extremely minor or very minimum, so it just doesn't react to it that much. If you go into the intramuscular regions of the cardiac muscle, they're going to have a lot of beta 1, beta 2 receptors on them, so they would be tending to be responding as vasodilation to a sympathetic tone. Now, I've made this point before, but when it comes to regulating vascular tone, regulating blood supply to an area, yeah, you could have sympathetic tone to the area, but the local metabolic demand, releasing various signals, releasing various chemicals, are going to be affecting vascular flow. So you may have sympathetics coming in wanting to vasoconstrict to a certain level, creating a certain vascular tone, but once that tissue starts working and releasing certain factors, it's going to cause those vessels to vasodilate regardless of the sympathetic input. Another side point here is I just got through telling you, you don't have many alpha-1 receptors, and again, they're not particularly active even in normal sympathetic tone, but there are some people out there that have an abnormally high number of alpha-1 receptors on their coronary vessels. And again, this is an aberration. Those individuals, since they have such a great number of alpha-1 receptors on those epicardial coronary vessels, when they have sympathetic stimulation, it causes those vessels to constrict, and they actually can have angina symptoms. But it's not, again, because they're having obstruction blood flow because of plaques or clots or whatever else. It's just that because of their biology of their heart, they have too many alpha-1 receptors, and so they're going to have angina type of symptoms. So again, local metabolics always are going to dominate over any type of sympathetic input. There are two general categories for beta blockers, selective and non-selective. A selective beta blocker, as the name implies, it's specific for a particular adrenergic receptor. In this case, maybe we would say we want a beta blocker that's acting only on beta 1. Well, then that would be a selective beta blocker. A non-selective beta blocker would have basically equal affinity for multiple beta adrenergic receptors. So they may have an affinity for beta 1 and for beta 2. So if we're talking about, your patient now is starting to have angina, typically you're going to want to start them on, if you want to go beta blocker therapy, you would probably start them on you prefer the selective beta blocker over the non-selective beta blocker and to initially treat their angina. Metoprolol is going to be a common selective beta blocker. Again, it's going to be pretty specific for beta 1. Propranolol is going to be a pretty common one for a non-selective beta blocker. Now, again, you have to be careful with these because, again, recall what type of adrenergic receptors do you have in lung for smooth muscles in airways? Well, those are dominated by beta 2s. Well, what would happen if you gave your patient a non-selective beta blocker, and so now you're like propranolol, and now you're also blocking the effect of beta 2 interaction with norepinephrine or adrenaline? Well, in that case, you're going to have a problem with lungs. So, that being said then, reactive airway disease is considered a relative contraindication for non-selective beta blockers. If your patient is having a problem breathing, if you're having spasms of the smooth muscles of the lungs themselves, the last thing you want to do is to give them something that's going to cause those beta 2s to be blocked. And so that would be a case where you probably wouldn't want to give them a non-selective beta blocker because you're going to exacerbate the problem. So if they've got a history of bronchospasms or whatever, you really want to be careful about giving them beta blockers at all. And if you do give them a beta blocker, make sure it's selective, make sure it's short half-life, and you want to monitor them very closely for adverse effects. So again, things you have to think about in terms of what else is wrong with my patient, where I could have a drug for one particular malady, but again, I have a deleterious effect because of something else going on. So what I want to end this with just kind of going back over something about affinities. I've talked about this. The effects of drugs, like most drugs, is going to be dose dependent. And so again, for drugs, you have a function of selectivity. And selectivity is going to be how specific is the ligand and the receptor. Is it a very good match? You can have a drug or another ligand that binds to a lot of different things. Well, that would be non-specific. Or you could design a drug or there's a biological ligand that's very specific to a very docking point, again, and that would be called very selective. So you have to, when you're talking about drugs, is a drug selective or is a drug non-selective? Non-selective means you're getting a lot of interaction and a lot of effects that you don't want. So you'd want your drug to be pretty selective. Then the other thing you think about is affinity. Okay, the affinity is basically, when the drug or the molecule in question binds to the protein, how tight is that bond? And then we talked about this when we talked about oxygen binding to hemoglobin. You had a certain affinity. And of course, what we're talking about here is something that once bound can still be unbound, so it's not permanent. So the affinity is just simply how, when it does bind, how tight does it bind, which is going to determine then how long that molecule sits in that receptor slot. And if it's got a pretty good affinity, it's going to sit on there longer. It's still going to eventually dislodge, but it'll sit on there longer. So having these two concepts down, let's talk about, say, a selective beta blocker. Well, if I am giving the patient a selective beta blocker, which means that it's going to prefer, say, beta 1 over beta 2, and as long as I'm within a certain dosing, that's the case. But a selective beta blocker can become non-selective if the dose is too high. Because if I have enough of a molecule, even though I might have a low affinity for beta 2, I'm not saying it doesn't have any affinity at all. And so if I saturate the environment with a selective beta blocker, have a lot of them, then it's going to start binding to beta 2 receptors. So this is something you always have to be mindful of when you're looking at drugs. Okay, it has an affinity for this, but not this. They're really assuming at a certain dose, but as you raise the dose, then you start having issues in terms of binding to things that you don't want to bind to. So you may give a selective beta blocker, but if the dose is too high, it may start interacting with the beta 2s in the lungs. And so again, dosing is everything when you're talking about drugs and thinking about affinities. Okay, so that's a wrap for this, and we'll pick up next time. Let's take a look at a typical ECG or EKG. And what I have here is just a cartoon that is a generalization of what these look like. And I'll make this point again in a bit, but each of these ECGs look different depending upon what lead you're looking at. And we're going to get into this later, but a typical ECG has 12 different leads, and leads are just different ways of looking at the same event. Again, that'll make much more sense when I walk you through an ECG. But for right now, this is just kind of your stereotypical simplified ECG through a heartbeat. One of the things that you'll note when you're looking at ECGs is that it's going to be on a graph paper, and of course you have an x-axis and a y-axis forming little blocks. And so the x-axis, one block equals 4/100ths of a second. And so again, that's along your x-axis, and that is a number that I want you to know. And then in the y-axis, one block equals about 1/10 of a millivolt. And again, that is a number I want you to know. So I want you to have a sense of scale when you're looking at an ECG paper and you're looking at the little boxes, what the unit is in terms of your x-axis, which is time, and then the y-axis, which is potential change. Now, having said that, looking at this ECG here, I'm just going to point out real quickly, you have a QRS complex, and that's that big spike. This spike here is not an action potential. So you'll recall when we looked at action potentials, you had an out and an in terms of cell membrane, and then you have some kind of metering device, and then you are measuring the potential across the membrane, out versus in or in versus out, and that gets you your potential. This ECG is not that, okay? So you'll recall that with an action potential of a skeletal muscle, the action potential would look like this. It'd go up, and then it'd come down, and then have something like that, where that would be near the Nernst value for sodium. So this is in the area of 60 millivolts. And then it would cause you a little hyperpolarization and then resolve itself. And of course, it happens very quickly. So on first blush, you look at that and say, well, that looks a lot like the R wave. And again, no, they don't. This will help you get a sense of scale. So let's have a baseline here. Okay, so make that the baseline. So the distance from here to here is about 1 millivolt. And of course, you have the same thing down here. Again, 1 millivolt. So the deflection, you have a sense of scale, whereas from here to here is 60 millivolts. So if you were to compare this to this side by side, and you put it in scale, then of course the peak R wave here would be 1/60th of that 60 millivolt swing. But you are not measuring an action potential when you're looking at that. You're looking at something else, and again, I will get into that later in terms of walking you through why the pen on the paper moves up and why the pen on the paper moves down when you're doing an ECG. So that's coming, so I'm just going to have to ask you to be patient on that. But my big point is, this is not an action potential. What you're looking at here is going to be the change in the electrical field of your body fluids in response to a depolarizing event of the heart. And I'm going to, again, I have a whole nother lecture on this, and the lecture is called Heart as a Battery. So the heart really is a battery-like thing that has an electrical field around it, and that electrical field, because we are basically salt water, and salt water conveys or communicates electrical fields fairly efficiently, then if I have an electrical field in my heart and I'm a bag of salt water, then that electrical field easily goes through my fluids and creates various potentials in my body. And so when the heart is beating, which you know as a depolarization-repolarization event, then it is changing the electrical field in my body. And so what an ECG is, it is monitoring, or it is reading that change in the electrical field as the heart goes through its cycle. So let's go through and look at some of these labels here. Again, this is time in this direction here. And so we're moving in that direction. So the first thing we have here is a P wave. The P wave is going to be the change in the electrical field in the body as the atria depolarize. So the P wave represents the depolarization of the atria. Then as time goes on, okay, again, this is time moving in this direction, then what's up next is going to be a deflection downward, and we're calling that the Q wave. Then you have a deflection upwards, we call that the R wave, and then a deflection down again below baseline, and we call that an S wave. So this area here we simply refer to as a QRS complex. The QRS complex is what happens in the change of the electrical field in my body in response to the depolarization of the ventricles. Now, the QRS complex is going to be mostly reflecting the activity of the left ventricle as opposed to the right ventricle. That's a function of simple mass. The left ventricle is about 3 times the mass of the right ventricle. So the left ventricle dominates simply because there's so much of it. So the QRS complex is going to be following the P wave. After that, then we're going to have a T wave. And the T wave here denotes the repolarization of the ventricles. And technically, you'll note here the T wave, the slope here is a little less and the slope here is a little more, and that's typical. So a normal T wave doesn't have a symmetry of the rise and the fall. It's skewed to the right just a little bit. Now let me put in some other terminology for you. We have what is called a segment. And a segment is always a straight line. So what we have here then, we have an ST segment. And so the ST segment here is the end of the S wave and the beginning of the T wave. And again, it is a straight line. So if we're referring to a segment, we're referring to a part of this process here in terms of the cycling of the heart. There is no waveform in a segment. In distinction of that, we have an interval. An interval will always include at least one waveform. So we have in this case here, a QT interval right there. And it's from here to here, so the letters kind of tell you what's going on. Goes from the T, from the Q, beginning of the Q to the end of the T. And again, it is an interval because it has at least one waveform. We also have a PR or a PQ interval. And in this case here, they label it PR, even though there's a Q there. It is, a lot of times you'll also see this as a PQ interval as well. So you kind of see it both ways. But basically what this is, the PQ interval or the PR interval, again, we're calling it an interval because it has at least one wave, the P wave. That is going to be from the time the atria contracts until the ventricles depolarize and contract. So the P wave is the depolarization of the atria. So it will happen, then you have a little bit of a delay, and then you're going to have the ventricles contract. So in terms of an action, in terms of a depolarization event. So the PR or the PQ interval starts at the beginning of the depolarization of the P wave and lasts until the beginning of the depolarization of the ventricles themselves. We also refer to the QRS as typically a complex. There's another wave that sometimes is present, but I don't have it on here, so I'm just going to draw it on here. And it's going to be something like that. Choot. And that is referred to as a U wave. Most of the time it's not there, but sometimes it can be there. So the U wave is thought to be the repolarization of some Purkinje fibers. Someone having a U wave could be perfectly normal. Maybe they've always had a U wave. Sometimes you'll see a situation where someone, if you know their history, will not have a U wave, then all of a sudden they do have a U wave. It may or may not be a point of concern, but we will say that the U wave could indicate a pathology. It may or may not be anything. But if you had a patient and they've never had a U wave, then all of a sudden they have a U wave, it's a sign that says you might want to look further to see what's going on with this individual. Now let me return to the P wave for a second. And again, P wave being the depolarization of the atria. P waves, typically what you have, I just kind of draw it out cartoon-wise there and there and there. And so since it's the depolarization of the atria, it's actually two parts. So the first part here, that is going to be the depolarization of the right atrium. And then the last part here is going to be the depolarization of the left atrium. So you could have a situation where if there is a delay between the right atrium and the left atrium, and remember we have a node that crosses over from the right atrium to the left atrium, if that is delayed, you could see a P wave that looks something like that. A little dip and then something like that. Well, if you have a little dip there, that means there's just simply a little bit of a delay between the depolarization of the right atrium relative to the depolarization of the left atrium. You can also see various forms of the P wave, particularly if there is a pathology. You could see it where, I'm going to draw it down here, you can see instead of being that, it could be this. Okay, you could go up, loop, and do that. That could be a P wave, or you could have an inverted P wave, something like that. Now again, these are going to be indicating that there's something different about what's going on in the atria as they depolarize. And again, this will make more sense a bit later. But again, if you have an abnormal waveform of a P wave, then again, it's an occasion to take a look and see what's going on. The normal time between a QRS complex is about 0.83 seconds, and that works out to be about 72 beats per minute, which is in the range of a normal sinus rhythm. Let me say a couple of things about the T wave again. So your T wave, which typically we're saying is that one there, they don't look that way in every lead. Remember, we got 12 standard leads, 12 different perspectives of what's going on in the heart. So when it comes to a T wave, if you're looking at the AVR lead, and again, this will make more sense when I walk you through all the various leads names, so just bear with me on this. And you might want to, when we get to that, come back and look at this lecture so that you now want to know what an AVR lead is. But typically, the T wave in an AVR will be inverted. Which means it's going down as opposed to up. So that would be normal. It could be inverted in leads AVL, lead 3, and lead V1. Again, this will make more sense later. So the T wave, what it looks like is really going to be dependent upon what lead you're looking at. The T wave is largest in leads V2 or V3. Speaking of largest wave, going back to your P wave, the P wave is largest typically in lead 2. Another marker that I want you to know, again, this will become relevant later, is right there at the end of the QRS complex, at the front end of the ST segment. We're going to be referring to this as a J point. Again, I will elaborate a lot more on a J point in a coming lecture. Let me tighten up the definition of some things here. A Q wave is defined as the first deflection down before the R wave. So it's going to be, by definition, following the P wave. So now I'm returning to baseline here. So I got my baseline there. And so the first wave down after the P wave, but before the R wave, we define as the Q wave. I guess my point also here, just because you have a downward wave doesn't make the Q wave, because we clearly have an S wave is also downward, but it's not a Q. The R wave, okay, that's that guy up here on this lead here. The R wave is the first deflection up following the P wave. Now you may say, why didn't you say following the R wave? Well, because a number of leads, you may or may not have a Q wave. You may have a P wave, returns to baseline, and then just goes up. So the R wave may or may not follow a Q wave. but we can say that the R wave is the first deflection upward following the P wave. Now, it may or may not follow a Q wave, so it just depends. And we're going to find out on the next page that sometimes you'll have a double R wave, and if you do, that second R wave is called R prime. Okay, and again, I'll talk about that on the next page. The S wave is the first downward deflection following an upward deflection. And if the upward deflection is an R wave, then typically we're saying the S wave follows the R wave, but the S wave has to drop below the baseline here for it to be an S wave, because the S wave by definition is a downward reflection below the baseline here. So we're going to get into that again on the next page in terms of how you name things. Another thing that I want to make sure that we understand, and again more on this later, in your typical ECG, in this one you see the R wave is much higher than the S wave. And that is true in some leads. In other leads, the R wave is going to be small, and then the S wave is going to be very large. And that would be typical for some of the other leads. So I don't want you to walk away with the impression that the R wave is always larger than the S wave. It's not. It depends upon what lead I'm in. So there are some leads where normally the R wave is bigger than the S wave. Some leads, the S wave is bigger than the R waves. But if you have a lead that normally the R wave is larger, but now the R wave is smaller and the S is larger in a lead where that normally is the case, that's going to typically indicate some sort of pathology. Again, we're going to get into that a lot later on. So the last point looking at this is that there is called a TP wave. A TP wave, if present, or if you can see it, is the repolarization of the atria. Now, you look at this wave here, or look at this ECG here, you don't see the TP wave. The reason you don't see a TP wave, because when is the atria repolarizing? It is repolarizing during ventricular depolarization. So the QRS complex covers up the TP wave. So you normally don't see it. Now there are pathologies such that the QRS complex is not happening during a repolarization of the atria. And if the QRS complex timing is such that it doesn't mask when the repolarization of the atria occurs, then you can see a TP wave. So the ventricles depolarize, QRS, they repolarize, T wave. The atria depolarizes, P wave. The atria repolarizes. But typically it happens when you have the depolarization of the ventricles. All right, so hoping we're having some basic vocabulary here. I don't want you to memorize these numbers here. Don't worry about those numbers. Again, it's just giving you a sense of how long they last. Of course, you can figure that out if you understand the time that 1 square is 4/100 of a second. So definitely know these numbers, but I'm not worried about you knowing these numbers here. So let's now move to some nomenclature. So this first one here is the one we just had. So you have your baseline, you have your Q, you have your R, and you have your S. Next one over, here we have no Q wave, so there's no Q here. We have our deflection, and we're just kind of assuming there's a P wave over here, okay? We're just going to assume there's a P wave. Okay, so the first deflection upward following the P wave is going to be the R wave. And then if you have a second R wave, then we're going to call that an R prime. Now this one gets a little weird. in the sense that in literature that is called a RSR prime wave. Technically, it shouldn't be called that because technically that's not an S wave. Okay, that's not an S wave. For an S wave to be an S wave, it's supposed to drop below the baseline. So technically it's not really an S wave, but people have gotten used to calling this particular waveform an RSR prime, so technically it's incorrect, but it's been accepted. So if you hear an RSR prime wave, that's what they mean. Over here, you have an RS wave. So there's no Q involved here, and this is very typical. Okay? In fact, if there is an R wave present, if there is a Q wave present, it's very small. If you have a large, robust Q wave, that typically means there's a pathology, and again, I'm going to talk about that later as to why that is typically a pathology. But if there's a Q wave present, it's usually pretty small. Over here, we have a Q, and we have an R. But again, it doesn't deflect down below the baseline, so you would simply refer to this as a QR wave. And the one down here, we have one sole deflection downward, and they just simply call this a QS wave. So when you hear the word QS, it just simply means one single deflection downward. Seems like to me you just call it a Q wave or an S wave or something, but that isn't what nobody asked me what to call it. So in the literature, you just refer to it as a QS wave, one tick down. And then lastly, one tick up is just simply an R wave. So again, you're going to hear these in literature or read these in literature, so now you have a better sense of what they're talking about. So let's go back and take a look at the action potential of the ventricle. Now this is an action potential of the left ventricle. And again, it's going to, in this one here, they've got it going up to about plus 20 millivolts. And what I've did is I've kind of matched the ECG reading with, in terms of time sequence, with what you would have as an action potential, the depolarization of the ventricle itself. So again, reminding you of scale, this is basically 1 millivolt. Okay, so these two are not scaled together in terms of the y-axis, but I did have them scaled together in terms of the x-axis, so I wanted to match the timing up. Of course, time is moving in this direction here. So what you see here is this is the QRS complex here. Again, it is in line with the beginning of the depolarization of the ventricles. But note that the QRS complex is well over before the action potential is over for the ventricles themselves. So most of the time of the action potential, you're in basically an ST segment. And then what we have as the tissue is repolarizing, so we're heading down towards the repolarization, so somewhere along in here is going to be your T wave. So your ventricles are going to begin repolarizing as this thing here goes down. And of course you return to baseline here, and then you do it all over again. Again, the time here is about 300 milliseconds from here to here. Okay, so again, wanted to give you a sense of what's going on. Again, the time is to scale, but the y-axis is not. Okay, this is 20 millivolts, and this is 1 millivolt there. But again, I just wanted to see so you can understand what's happening in relation to what else is happening. Now, another thing that I want to point out here with this cartoon we have up here. And that is, you will recall that when we looked at action potentials for skeletal muscle or for neurons, we had a refractory period. And again, this goes back to when the voltage-sensitive sodium channels, remember it's a two-gated channel, H gate, M gate, and so when you have that initial depolarization, it deactivates. And that voltage-sensitive sodium channel is not open for business until the membrane is repolarized. So if you try to open it back up before the repolarization has occurred so that it can reconfigure its gates for another round, it's not going to open up. So you have a refractory period in the action potential of a neuron or skeletal muscle. And you'll also recall that you have an absolute refractory period and then you have a relative refractory period, which is at the end of the action potential of the neuron or skeletal muscle fiber. And that we define as you could have another action potential, but you're going to need a bigger stimulus for it. Okay, so I want to do the same thing with the action potential of a cardiomyocyte. And as I said before, it looks very different because it takes a much longer time. An action potential of a skeletal muscle fiber or a neuron is about 2 milliseconds. Whereas the action potential of cardiomyocyte is 300 milliseconds. Remember, you got that plateau area up here. Again, if it's plateauing, that means I'm having movement of charge, but I'm having a no net change of charge. I maybe have calcium coming in, but I've got potassium leaving, and so it's even during that plateau phase. And it's only when the L channels, calcium, begin to close, and then I'm having more potassium leaving the cell than I am calcium coming into the cell in terms of number of charge that the membrane goes down. Okay, so this first light green here, from here to here, that is the absolute refractory period. The tissue is completely unexcitable. Nothing you're going to do that's going to bring an action potential about. Then you have another, and you see this all the time in literature, called the effective refractory period, or the EPR. And so the effective refractory period is going to be here, and then just a little bit of that darker green there. So that is going to be, again, the absolute refractory period, plus a little short segment during your phase 3 here, in which a stimulus may cause a cell to depolarize minimally, but will not result in the propagation of an action potential. In other words, a neighboring cell will not depolarize. So what we're talking about here is going to be just this little area here. So I just want to make sure that we're clear. The effective refractory period is simply a period of the depolarization phase of the cardiomyocyte where even if you could kick off another depolarizing event in this darker green, it won't be enough to where you can start the chain of events going from cardiomyocyte to cardiomyocyte. So the effective refractory period simply means that you can't get the reaction going from cardiomyocyte to cardiomyocyte. So the effective refractory period has two parts, the absolute refractory period, and then a little bit after that. But during any of this, it doesn't matter what I do, there's no way I'm going to start a chain reaction of one cardiomyocyte causing the next door cardiomyocyte to depolarize. Now, you can't even have an action potential during the absolute, but if you could have a little action potential in that last tail end, but it's not going to lead to another action potential in the next adjacent cardiomyocyte. So we just simply call that the effective refractory period, which means regardless of what happens to the cell, it's not going to kick off a chain reaction causing the next cardiomyocyte to have an action potential, and so forth, so on. After that, then you have the relative refractory period. The relative refractory period is just going to be this area here, and this is where it overlaps actually. So from here to here. So I'm still including that little green there, and then I have the yellow here, and this is where you can have a action potential, okay? But it's going to take more stimulus to cause that action potential to occur. Now again, you have the little double color here because I said in that little green there, I can have an action potential, but it's not going to talk to the next cell. Whereas the yellow here, I can have an action potential, but now I'm getting into the phase where I could have the domino effect of one cardiomyocyte tripping off another cardiomyocyte and having a chain reaction of action potential wave going through all of the tissue. So just make sure you have clear in your mind that little strip of green. You have to think about it a little bit, but that's what that is. So relative refractory period, greater than normal stimulus will depolarize the cell and cause an action potential. Will that action potential cause an action potential in the next cardiomyocyte? Depends. If we're in the yellow, yes. If we're in the little green strip, no. And then finally, we have a supranormal period, SNP, and that's going to be this area here. And this is a hyperexcitable period which a weaker than normal stimulus will depolarize the cells and could cause an action potential and then also a chain reaction with the next adjacent as well. The cells in this phase are particularly susceptible to arrhythmias because, again, so you can get a problem going on if you have an action potential during that supranormal period. Susceptible to arrhythmias when exposed to an inappropriate timed stimulus, which is why when you are doing a synchronized electrical stimulus to bring a heart back to normal sinus rhythm, when you cardiovert, you're going to have to be very careful in terms of the timing. Because if you try to give an inappropriate signal during this little pink phase right there, the supernormal, you can actually kick them into ventricular fibrillation. Now, I probably tossed a bunch of words at you in that last bit there. I am going to go back and we're going to talk about cardioversion and defibrillation. I have a whole block on that, so just hang tight. That is going to become more clear to you in a future lecture. The reason that you have a supernormal period is because by the time you get into the pink here, the voltage-sensitive sodium channels are all set to go again. They're ready for the next round, except you're in this area here where you have not returned to baseline yet, so therefore you are closer to the threshold of these now ready-to-go voltage-sensitive sodium channels that they're easier to depolarize. Again, because this line is above baseline, they're all ready to go, and so it takes less input to cause that reaction. So you're going to hear these terms often in cardiology, particularly the EPR. You'll see that all the time. So again, basically what it is even if you did have an action potential, it's not going to go anywhere in terms of the next adjacent cells. Okay, the last thing that I want to show you in this is going to be kind of lining up to give you a better understanding of how things are when you're comparing the action potential and contraction of a skeletal muscle and the action potential and the contraction of a cardiomyocyte. So you'll recall you have an action potential here. It goes up, it comes down, and then you have your contraction of or twitch of the muscle fiber. So this is tension on this one. So you have your action potential, the depolarization, and then follows the twitch. So again, understand the timing. This is going to be 1 to 2 milliseconds, where your twitch could be, 50, 60 milliseconds. So you have that. And again, if you want a more forceful twitch, a stronger contraction, then you can do temporal summations and pop, 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 and then this is just going to go higher and higher and higher. So we've talked all about that. Now let's take a look at the cardiomyocyte in terms of contraction and action potential. And I talked about this a little bit earlier when we were talking about the action potential of a cardiomyocyte. You notice you have your plateau phase there, but look at this. So you have your action potential here. Note that the contraction of the cardiomyocyte is a bit delayed, okay? So it's covering here. So the contraction is a much longer time than the twitch of a skeletal muscle fiber. So it's spread out over a longer period of time, and you're going to note that as this is plateauing, this is the main part where I'm actually having the contraction itself. So the action potential doesn't end until here, and so that's about where my contraction is almost done. And you'll recall that this is advantageous for this tissue to have this long plateau here, because I would not want to have a quick action potential and then have this long contraction, and now these guys are ready to go again. So if I start popping with more action potentials and I'm in the middle of the contraction, no good comes from that. Okay, that's not a good design for the system. You're going to kick in arrhythmias, etc. So that's not how you'd want to design this system. So what you want is you're going to want I want a nice long plateau, so that I want this to be in a plateau phase during the contraction, because I don't want any other electrical activity happening to disrupt the timing of this. So it's very important that the contraction timing is going to mirror the timing of the action potential of the cardiomyocytes. Okay, so hopefully that is helpful. We'll pick up next time. In this last section of cardiac muscle basic, I want to return to another look at the electrical circuitry of the heart, and I want to tie this into some embryology and then the innervation of the parasympathetic and the sympathetics. As I've said before, the internodal pathways, specialized myocardial cells that rapidly conduct current from one point to another point. Histologically, if we're talking the ventricles, these are, again, non-contractile, so they don't have much in terms of striations. They may have some indistinct boundaries. Now, this is in distinction for the internodal pathways in the atria, which, again, they're very difficult to see because the internodal pathways of the atria are, in fact, contractile, so they're indistinguishable from the surrounding cardiomyocytes that also contract. And as I've said before, the pacemaker nodes are heavily innervated by sympathetic and parasympathetic. So again, you have a sympathetic tone coming into the heart. You have a baseline parasympathetic tone coming into the heart. So as far as the heart is concerned, the autonomics, I got a little bit of pressure on the brake pedal and I have a little bit of pressure on the accelerator, and they're working off each other. If we're talking about the preganglionic sympathetic fibers to the heart, they're going to arise mostly from the stellate ganglia. Now, the stellate ganglia is going to be the ganglia that is formed when you have your inferior cervical ganglia and it fuses with your first thoracic ganglia. And some people have a stellate ganglia, some people don't. So some people, they have a separate inferior cervical ganglia and a then discrete T1 ganglia. So when that happens, then the input can be from one or the other to the heart. But if they're fused, then they're coming from the stellate ganglia itself. So if you remember, the postganglionic fibers are the fibers that actually make it to and act on the end organ itself. So if that's a little fuzzy to you, I'm asking you to go back and relook at the autonomic notes so you can get a better sense of what we're talking about. The SA node is developed from the right side of the embryo, which is why it is supplied by the right vagus nerve and right side sympathetics. So here's the SA node, develops from the right embryo, and it's going to be fed by the right vagus nerve and the right side sympathetics. Whereas your AV node develops from the left side of the embryo, and it's going to be supplied by the left vagus nerve and the left side sympathetics. So the AV node is going to be the left. Now, this is not that hard to remember, because if you are looking at this, from anterior posterior, this is right side and this is left side. And so you could split it up. So what's on the right side is going to be your sinus node. Well, that's right side embryo, left side just a little to the left. And so that would be an easy way for you to remember the left sympathetics, left vagus nerve, right sympathetics, right vagus nerve in terms of what innervates which node. So I don't think that's hard to remember. All right, so a clinical point here, you've heard of what is called a carotid massage. And this is something that a healthcare worker can do to actually slow the heart rate down. Now, this is something you would never want to do to anybody else, because there are possibilities of things going bad with a carotid massage, but in the hands of a professional, this is something that you could do. So let's talk about what a carotid massage is. So if you recall, the carotid massage is going to be associated with a carotid sinus. Carotid sinus there. The carotid sinus is going to be that area right where you have the bifurcation of the common carotid artery as it bifurcates into the internal carotid artery and the external carotid artery. Right there is a sinus, and that sinus contains numerous baroreceptors. So that's the area there that is basically sampling arterial blood pressure. So what's going to go on here is that carotid sinus, innervated by the glossopharyngeal nerve, I guess cranial nerve 9, glossopharyngeal, and that particular nerve that innervates it's called the sinus nerve of Herring. It is a afferent fiber. In other words, it is basically there to sense something at the carotid sinus, and what it's sensing, of course, is pressure, and then it's going to be communicating back to the central nervous system. So it's going to be delaying information from that sinus, and it's going to communicate back to another structure called the nucleus tractus solitarius, which is located in the medulla of the brainstem, or the medulla oblongata. So the lower part of the brainstem, there's a cluster of neurons there, and they're called the nucleus tractus solitarius. It is receiving information from the baroreceptors from the carotid sinus being conveyed by the glossopharyngeal nerve, in particular the nerve of Herring. So once that information is communicated to these neurons here in the medulla, that then is going to be communicating the information to the dorsal motor nucleus of the vagus. The dorsal motor nucleus of the vagus is also a cluster of neurons sitting in the medulla of the brainstem. Those neurons are motor neurons, but they're motor neurons associated with the autonomics. So the neurons associated with the dorsal motor nucleus of the vagus will send their axons out, riding down the vagus nerve, and then will communicate to the AV node, SA node, and other areas of the heart as well. So the neurons of the dorsal motor nucleus of the vagus will ride down the vagus and will talk to the heart, and those are going to be your preganglionic fibers going to the heart, which means then they are going to then be communicating with other neurons very close to the heart. Then those neurons will in turn synapse onto the various regions of the heart, delivering their acetylcholine for their desired effect. As far as, and another thing that they're going to do, once you have the communication from the nucleus solitarius, again, which is going to be receiving the information, not only is it going to talk to the parasympathetic side of things, it's also going to be talking to your sympathetic side of things. And you'll recall the sympathetic nerves that are coming to your heart and the rest of your body, okay, they're going to be coming from your intermediate lateral cell column. In case your IML or IMLCC, remember that is in your spinal cord, that is T1 through T12-ish, somewhere along in there. Okay, and they're going to be giving rise to the postganglionic parasympathetic fibers. The postganglionic sympathetic fibers going to your various organs. So your IML or your intermediate cell column, that's your sympathetic system talking to your organs, in this case, the heart. So now I'm having my input from my parasympathetic component, vagus, and then my sympathetics, and talking to the heart. And so they are then communicating or modulating heart function relative to the signal that was delivered to the brainstem, the nucleus solitarius, telling the brainstem, hey, the pressure of the arterial system is this or that. So the reason that you'd want to know that is because if the pressure of the arterial system is too low, then what's going to happen, you're going to have an adjustment on that brake pedal and that accelerator. So if the pressure is too low, then you would want to maybe back off the vagal input and increase the sympathetic input to cause the heart to beat a little more forcefully and a little more rapidly to bring the pressure back up. Or if the pressure is too high, then you might want to lay off the accelerator, maybe tap a little bit on the brake. So you might want to back off on the sympathetic tone, increase the vagal tone a little bit to slow the heart down. So you have some modest ways of regulating blood pressure relative to heart function. So that's what the carotid sinus is all about. So we're using that knowledge to basically trick the system. So if you are then palpating the carotid sinus and just massaging it, what you're doing is you're increasing the pressure at that little area that you're massaging. And so if you're increasing pressure, basically you're telling the carotid sinus that, okay, I've got too much or I got additional pressure in the arterial system. I might want to go back up to the brainstem, let my autonomics know the pressure's running a little high, and then make an adjustment in terms of my parasympathetic, sympathetic, and slow the heart down. And that's exactly what will happen. So if you do a carotid massage on somebody, it's actually going to slow their heart rate down and lower their blood pressure. Now, when you do this, you don't do the massage more than maybe 5 seconds to get the effect. But this is a maneuver that could be done if somebody is in supraventricular tachycardia, if their heart is beating too rapidly, and again, it was one of many things you could do that's very simple to slow the heart rate down. It can also be useful in treating atrial flutter, also atrial tachycardia as well. Again, it is quite useful. Now, the reason that you just don't want to do it yourself is because when you are massaging the carotid sinus, that person may have plaques built up in there, and if you're physically manipulating the carotid sinus, you run the risk of compromising the integrity of the plaques. You may agitate them, they may break off, they may become a clot, an embolus. So it's pretty high risk in the sense of massaging those. You need to know what you're dealing with in terms of the patient. So this is why a normal person off the street, you would not want to do that, because you could end up hurting somebody by dislodging a plaque or something or causing an embolus. So again, this is something fairly serious. You want to be very careful about that. But anyway, so that's what a carotid massage does. And it's, again, it's one of the tricks in the bag that you can use to slow the heart rate down for somebody. My last topic is, this is just more of a practical thing. has nothing to do with what I just talked about. Basically, what I want to do here is show you a quick and dirty way of estimating the rhythm of a heart when you see an ECG. So you will recall that 1 square is 0.04, or 4/100ths of a second, okay? And you will recall that you go from QRS to QRS, and so if you could measure the time from here to here, then you can estimate or you can calculate what the heart rhythm is, but you got a lot of little small boxes between there. So you don't want to do that. There's an easier way to look at an ECG and very quickly determine what the heart rate is. So the way you do it is you memorize these numbers here: 300, 150, 100, 75, 60, 50. Just get that in your mind. That's what you do. So once you have that down, you have a very quick way of looking and determining what someone's rhythm is. So if you look on an ECG paper, you'll see the small boxes, okay, right along in there, but you also have big boxes. And so the big boxes would be there. Okay, and so as far as time is concerned, you're going to have 5 little boxes make a big box. So you got a here, and then here, and then here, and so forth, so on. So easy to see in ECG, the big boxes. So what you're going to do is you're going to look for a QRS complex, and ideally, if you can find a QRS complex where the R wave is going to be corresponding to one of these big box lines, like right there, and then you're going to quickly look and see where the next one is, and you're going to count big boxes. So again, this lines up with this. So remember, I got the numbers need to be assigned to the boxes. So the first big box is 300, second big box is 150, third big box is 100, fourth big box is going to be 75, so forth, so on. So if you were to look here, you got a QRS here, and I don't know anything else, but I'm looking at the big boxes, and I'm counting big boxes. 1, so I go 300, 150, 100, and the QRS is between 100 and 75, so you know then the rate is going to be somewhere in the normal range. So basically 1, 2, 3, and then a half. So heart rate here is probably around 80-ish or something like that. And so that'd be a pretty good estimate of what the heart rate is. So just get used to counting the big boxes. So if you were to look at an ECG and you saw a QRS complex here and you saw a QRS complex there, what would the heart rate be? Real quickly look at it. You know it's going to be 150. 300, 150. So the heart rate is 150. How? Because the interval between the 2 R waves was 2 big boxes. 2 big boxes, 300, 150, so 150. Of course, then you may go say, well, what happens if I don't have that QRS wave lining up to on a big box? You can still ballpark it. Suppose you have a QRS complex there, okay, and you have a QRS complex there. What's in the middle of that big box, and it's the middle of that big box, that's still 2 big boxes. So 2 big boxes, so that means if I have that interval there, my heart rate is going to be 150 beats per minute. So you can get pretty good at this, but you're going to want to develop this skill just to look at it very quickly, boom, 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 just 300, 100, 300, 150, 175, 60, 50, and within 2 seconds you can look at what the rhythm is. So again, a little trick and a little skill that you want to get good at. Anyway, so that's it. So that concludes our chapter on the basics of cardiac muscle. And so next we'll go into in more detail on some of the things that I lightly touched on in this section here. All right, so I'll see you next time.